Good day, good morning, good evening, good night, whatever it may be to you. Hope all is well. Gonna record, pre-recorded, obviously. 'Cause like I told you before, I'm taking some time. I'm gonna handle some things. But we're gonna go over this chapter, Pediatric Emergencies. It is pretty long, so grab you a snack and some drinks, and let's enjoy our time, shall we say? All right. So in this chapter, it's gonna be a special population. This population is, the old, the news, and we say the newborn, and then the pregnancies. We want to make sure we treat them the best that we can. We provide them with the most um, comfort care, and just as we go throughout our process, we want to make sure that we do the best for them. So we're going to go over all of that. All right, patients with special challenges. We're going to So when we talk about these, you got to think about we're going to cover all of them. We're going to talk about, abuse, neglect, homelessness, poverty, bariatrics. A lot of those are going to be talked about. We're going to turn around and talk about technology dependence. Some require machines that keep them alive. Hospice, end of life services, tracheostomy care, dysfunction, home of care. Or it says home care. Sorry, when we talk about that, is like in home, home nursing, things like that. So sensory deficiency and losses, and then our development disabilities. So on our pediatrics, the best thing that I can tell you about them, it's the easiest thing to remember, is everything on them is small, super small. So when they start to have an airway obstruction, it's small. It's going to occlude pretty fast. Lower airway restrictive disease, that's because everything on them is small. There's not a lot of room for things to go. Respiratory distress, failure, and arrest, guys, as y'all can know, that's going to be small. So little things, big things can affect them very, very fast. I'm going to go over some shock seizures and SIDS disorder. We're going to talk about, oh, that looks like the same one. Let's see what they say here. Uh, that looks to be the same one. All right, so trauma, as we know this, it's on every single slide, so we're going to skip that one. All right, what we want to do is we want you to recognize the pregnant patients, pediatric patients, and our geriatrics, which is our elderly. Those all are special needs because, and I don't mean just as in general as the age group, but they all require some, care pretty fast because their bodies are going to compensate very differently. As in, infants and geriatrics are kind of basically the same when you treat them. Is they go into shock very fast because they can't take their skin has thinned out, their temperature regulator is off, their thermostat does get thrown off a little bit. We talk about the pregnant patient again, the pathophysio of all of these. Um, let's see here. So the illness in children that children sustain, and their response to them vary based on age and developmental. We know that. It's important to remember that children are not small adults. They don't have the abilities to think, feel, compensate like we do as an adult. So we have to do our best to treat them. Depending on the child, his or her age, the child may not be able to tell you what's wrong. So it's us to do the best thing we can for them. The fear of EMS providers is to make pain and providers in pain that can make children harder to assess. People don't like taking care of kids. They can't tell you what's wrong. We have to figure that out as providers. Parents are the primary caregivers. They're going to be wore out, stressed, frightened, and they're not going to be thinking right. They're going to be very irrational. They're not going to have they're not going to be able to understand what's going on and give you the best information. Pediatrics is a specialized medical practice devoted to the care of young patients. It can be very challenging, y'all, because if you're not able to think fast and on your toes, you're just reliable. If somebody tell you what's wrong, you're not going to hear that from this age group. Um, so once you learn how to approach children, we want you to teach you how to start at the children's feet, get their brains, get their abilities to accept that you're not going to hurt them. You're there to help them You start at their feet and work their way up. Tell them what you're going to do before you do any of it. We'll get you some brownie points to moving forward to taking care of them. Children often respond to treatment much more rapidly than adults do because it doesn't take long for something that you do to act in a child. Because, like we've said, little things affect them in drastic ways. So that's where they respond a lot better. So here, communication with the patient and the family, that's important because they're going to be the ones that tell you your history, your AFPU, your sample, all those mnemonics. That's where you're going to get. Uh, the family members, parents, are the ones also going to need some emotional support. Maybe you need to hug them and be like, listen, it's going to be okay. We're going to take care of you. We're going to get this taken care of, da 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 da, just so they know that you're there and you're going to do the best for them. That may be what they need. Um, the parent sometimes has the ability to help you with the child's patient care. Just depends on that particular patient. An agitated parent is going to tell the child that it's okay to be that way. Then the child's going to be that way. So if you can calm the parent, the better off you are. Remain calm, efficient, professional, and sensitive. I've told y'all from the get-go, your bedside manner will stay with you for the rest of your career. So if you don't chill out and you don't calm down, you don't treat your patients with the best, it's gonna follow you. So no matter what's going on, stay calm, be very professional, and have that loving, tender size. So here's our breakdown here. Childhood stems from the birth until 18 years of old, 18 years of age, shall I say. So here's how they break it down right into here on the age. Infancy is first year of life. So from birth until 1 year, they're an infant. Toddlers 1 to 3, preschool 3 to 6, school age 6 to 12, adolescent is 12 to 18. Once they become an 18, they're registered as an adult at that point. Depending on your facility, some trauma centers will say, anything 12 and up go over to the adult side, or anything 18 and under goes to the pediatric side. It just depends on that your medical facilities in your area, but that's something that I can't teach you that I just because every place is different. So that's just something that you're going to have to learn once you get out there on the streets. All right, so infancy is usually defined as the first year of life. They little, they duns. The first month after the birth is called neonatal, or newborn is from 0 to 2 months. Infants less than 2 months spend most of their time sleeping or eating. Man, I wish I could do that. Oh, I would like to just sleep. I don't need to eat. I have some reserve, but I need some sleep. I tell you. All right, so they respond mainly to the physical stimuli, such as light, warmth, hunger, and sounds. They know voices. They know they want. The only way that they know to tell you it's time to eat is by crying. They can't just be like, "Hey, yo, bro, I'm hungry." They can't do that. So they cry. That's how we know that something's wrong with them. Infants sleep for up to 16 hours a day, and sometimes between the difference in the caregivers that may interrupt different. Some kids have their nights and days swapped up. Parents can't sleep. Oh, stressful. Infants should be aroused easily from the sleeping state. Infants cannot tell the difference between parents and strangers, but they know smells, they know sounds, they know all that. So I'm not going to say that it's just an unknown, but they do know the difference. Crying is the only main mode of expression that they have. So that's their way of talking, is just crying about it. All right, so 0 to 2 is our infants again. The best thing we can do is soothe them, include holding, cuddling, rocking. You could just swaddle them still. Um, Hearing is starting to be developed at birth. An inconsolable infant, after obvious needs have been addressed, could be signs of illness because something's wrong. They're going to have the sucking reflex. Your head control is starting to be limited. Uh, Also, predisposed to hypothermia. They gonna get cold quick. You need to keep them warm. And it's often necessary to bundle the infant during your assessment. Unbundle, sorry, remove clothes. But you don't want to leave them out for too long because them babies gonna get cold. We got to keep them things warm, or otherwise your job's gonna be worse. Now we're moving into the infant from 2 to 6. They start to be all these lovey-dovey things at this time. They're getting chunkies. It makes them a little bit easier to evaluate at this age. I'm not gonna say that they're easy, but it's easier. They do spend more time awake. You start to get your facial expressions, their eyes, and when they see you, they may goo and smile. And then they're starting to recognize who the parent is. They know the caregivers. They start to understand brain functions and mental thoughts and all this point at this time is what they say. And at this point, they may start following objects with their eyes. So you can see some eye to head movements. Their head starts moving around in circles. Um, you will use both hands to examine an object. Both of them they'll grasp and try to hold, squeeze. The first thing it's doing is going to their mouth. They say 70% of the infants sleep at this point by 6 months. I don't know about that. I don't think mine ever did. I think mine just was always up. I swear, that's what I say. They never slept. Um, at this point, they're gonna start to roll. They're gonna start to get body motions, and they will rolling around, start trying to move their legs all over the place. And again, persistent crying, irritability, or lack of eye contact can indicate a serious illness. I'm not sure about depressed mental status or the delay in development. Super quiet ones, that may be the point. That's how they start recognizing it. 6 to 12 months. During the stage, infants begin to babble. They coo, they talk, blah, 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 their fun stuff. By the first year, they say their first words. Well, I suppose some may say a little bit longer. They start to crawl and walk. They start to the little bobble, the up and down, the bouncing back and forth, not knowing where to do, and they fall a lot. Predisposed at this stage, at the age group, to increase physical danger because they're able to reach up, they grab, they can pull on things, tablecloths, stuff like that that will fall towards them. So infants in this group also start teething. They explore the world by putting objects in their mouth. But I'm pretty sure they've done that from the get-go. They start putting things in their mouth, and that's just the way that I've always seen them. They may start crying a whole lot more when their parents or caregivers are going away, so they call this separation anxiety. Uh, Persistent crying or irritability can be symptoms of a severe illness. So again, crying is the best thing that we can have from a baby until it's time they can start talking to us and telling us what's wrong. I begin assessment by observing the infant from a distance. Let the caregiver continue to hold the baby during physical assessment because that's what they're used to. When a baby comes to you and they don't start crying or they don't start fidgeting to get away, something potentially could be wrong. And you want to provide as much sensory comfort as possible. Um, when you go to touch this child, like it says there, warm the end of the stethoscope because it's going to shock them. They'll start crying because it happens. So think about that. Everything you need to do needs to be warmed. Um, what you want to, when you start assessing these babies, you need to make sure that it is very efficient and you don't do intermitting, that you do it from the get go and you finish it. Start to finish is done, so you know. And tell the caregiver or the parent what you're going to do. Um, and it may upset the baby's overall. Sorry, I got distracted. Tell them what you're going to do because this procedure that you're going to be doing, you should expect a reaction out of the child. So the parents and caregivers not surprised me like, "Whoa, what are you doing? What are you doing?" I don't, and so it's that. So you know that it's going to be different. Expect something to happen. Oh, let's see here. Toddlers experience rapid change of growth and development between 12 to 18 months. Toddlers begin to start walking on their own. They're able to open doors, drawers, and all sorts of bottles. So it starts to get to the point where you have to be on your guard a whole lot more, and you're just protecting them. You have to not just let them lay on their back and play with the little swing thing no more. You're a lot more busier as a parent or caregiver. Um, because they explore by nature, there's nothing for them to be afraid of. Um, they don't know uh, they don't know what to be scared of. That scare is a learned ability. They have to learn to be scared. So at this point, nothing scares them. They have 100% faith of everything. Um, so at the same time, that's scary as a caregiver. Whoop, that they just don't know what to be scared of, so they just do it. They start at this point. They mimic what they see by older siblings, parents, eating, drinking. They start to mimic those things. They might start, carry on a conversation with you. They do know their major body parts at this time. And because of the lack of molars that they have, they may not be able to chew a whole lot of food, but they start chewing at this point. They gum it. They don't have any teeth at this time, but that's where you start getting your choking. It's because they stick all of it in their mouth, not just bits and pieces like we try to teach them. So they go for it all. That's where a lot of you get these calls from my baby's choking, they've quit breathing, and that may be why, is because they've full. So the mind of the toddler develops very rapidly in this stage from 18 to 24. The vocabulary words will increase from 10 to 15 words to sometimes 100 or more. They will be able to name a common object to you as you point to it. They'll tell you apple, car, truck. They pick these things up. They begin to understand some cause and effect, like if I pull on this, this is going to fall, or if I knock my cup over, it's going to leak. They start get their balance more. Their normal gait as they start to walk improves rapidly during this time. Now they do start running and climbing also in this age. Sometimes we wish that they weren't able to, but guess what? We can't stop that. That's called growth. Toddlers at this stage tend to start climbing to their parents and caregivers. And they often have an object that comforts them, a blanket, a stuffed animal. Um, those are the binkies, the toys that we need to make sure that we have close to them because that's a sign of comfort. If you have that comfort object, I recommend you bringing it with you. So assessment, they may have a stranger anxiety. That's why we start at their feet, work our way up. We don't start at the head because then they are going to start fighting us from the get-go. They may resist separation from the caregiver, and that's okay. Allow them to hold onto the caregiver or that special object, a comfort measuring, whatever you want to call it, as long as they can. They may be very unhappy about being restrained or held for this particular procedure, or when you go to start an IV, you may have to help your partner hold them down to get this IV done, and know that it's not for the worst of them, it's for the betterment of them. And then at this time, when you start to try to ask these kids, baby, can you tell me where you're hurting? They have a very hard time describing what localized pain is. They just know that it hurts, and it hurts bad. This is where we use those circular faces, where you see in the hospital. Tell me how you feel. Smile here, smile there. Which one is the worst? Those help us out a lot. You sometimes can distract them with a new toy or a new object. Uh, Blowing up a glove and allow them to draw a face on the glove or take their attention off of that. Begin your assessment at the feet. I've said that multiple times. And away from the localization of the pain, If the pain is at their right arm, start at their left toe, work your way up. If they start crying a whole lot, we know that that's signs and symptoms. And at this time, the babies, you know, they know that they still learn to cry when it hurts. I mean, us as adults still cry when things hurt, and mentally or physically or emotionally, we have a right to have feelings, and that's where we are. Uh, let's see, skip that. So the preschool days, 3 to 6, starting to go to school. We're getting them out of the house finally. They're able to use language effectively and tell us what's going on. They walk, run, talk, scream, jump, skip, all through these phases of life right here. They start good to go. Now we're going to have to just figure how to get them to talk to them. Their imagination is so massive at this point that they tell you all such of stuff, and then they fear pain like it is nobody's business. And then we say may believe injury is a result of bad fear, result of fear or bad behavior, and that's not the case. We just got to remind them of that. Let's see here. Learn which behavior are appropriate and which behaviors will lead to a timeout. It's what they learn. Tantrums. Whew, whew, we know terrible threes, terrible twos, all in this age group. Um, Foreign body aspiration. They may start choking on stuff because they still don't grasp the point of bite, chew. They just stuff and chew, and they can understand. They can understand simple and specific directions, as in like show me with one finger where it hurts, and they're able to do that. They're able to describe that a whole lot better than what we've come from in the past. Especially because they come from not being able to tell us nothing. So we start our assessments. Most of your history, all your mnemonics and all that are going to be handled by a caregiver. Well, that's important. We need to get as much information as we can, even if they're able to describe the history and tell us everything that went down. That's okay. No problem. And just don't lie to the patient. Don't. Yeah, I'm sorry. Sorry, I had to make sure I was on the right track with my notes. Got off page. When you go to tell your patient what's going on, don't lie to them and tell them it's not going to hurt. Say this is going to be uncomfortable. This is what's going to happen. This is how we're going to do it. Blah 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 blah. And just tell them. It's easier to be upfront to it. Sometimes they may withdraw from it, but that's okay. You just need to let them know what's going on. Sometimes you can distract them with an object or a toy, but remember these kids are they smarter than what we think they are. Again, start your assessment far south and work your way up. Bandages or your friends. I tell you, when I worked the truck a lot full times, I spent more money at the dollar store buying band-aids that had all sorts of colors and animals and all that. And just because I could let them pick out a band-aid was meant the world to them. So if I was able to let them pick 15 band-aids and we go to the hospital with that, that's fine. I had their I had their trust then. So some things like that may be beneficial to you. And the last one's very important. They're at to the point now to where their modesty is big to them. And so try to remember that when you're assessing them as much as you can, is remember to keep their modesty at the utmost comfort because you got to protect that because they will remember that. All right, school age kids. These are the ones you want to punch. I mean, love to death. Sorry, I'm just kidding. My baby, she's 7, and I'm ready. Whew, she's going on 36 though. Children this age begin to act. They think they act like us. They understand things a lot better than what we think they do, and they can respond to sensible to questions. They're able to help take care of themselves. They can tell you what happened. They may not tell you the full story because they're worried. Uh, we want these kids to be in school at these ages. I know sometimes that they may not be to multiple reasons, but school is very important at this stage. And concerns about popularity, peer pressure, and looks are very important at this age. When it comes to children with chronic illness or disabilities, that can become a lot of self uh, consciousness about. They feel like they're not fitting in, picked on about their size, and kids are not very cool at this age. They're rude, they're disrespectful, they're not as nice as they can be. They're just, I call them turds, but they are. At this stage, children understand death, and it is the final. There is no coming back. There is no redo. Death is the end of all things. Um, but their understanding of death is why it occurs is still they don't get it. They don't know why it happens, and their anxiety is going to be increasingly about the injury and illness because all they know is death is it. If something happens, they're worried about that. It's very hard for them to deal with that. School age years, you'll assess these. This is where you can start moving up to you'll treat them like adult. Ask questions. You don't have to start at the feet anymore. Talk to the child. Listen to the caregiver, but at the same time as give that child the ultimate respect that they deserve and talk to them. Let them tell you what's going on. The child may be more familiar with this process than what we think they are, and they may fill your brain with more information than you can imagine. Um, they may or may not make the assessment easy because of their experience of what's going on. Uh, at this time and age, you can start at the head and work down, or potentially go to that area that is ugh, that area is affected because they know it's going to hurt anyway, and it already does hurt. So you may be able to start with that area as an assessment. If possible, give the kid choices. Let them choose. Would you like to sit up? Do you want to lie down? Would you like to roll your pants up so I can see your leg where it hurts? Ask only the type of questions that let you control the answers. Don't ask yes, no, maybe questions. I need you to do this. Let's see. Need you to show me that you can do this. Don't bargain or debate with the patient. It is not up for debate. This is what's going to be done, and this is how it's going to be done. So those will get you on the winning side a lot better than what we think. Allow the child to listen to his or her own heartbeat. Put the stethoscope in. I mean, hell, I still think it's cool to listen to kids' heartbeats and let them because you get to watch their faces, and then now they understand what's going on, so they're able to be like, "Whoa, that's me! Oh, come on!" So give them simple explanations about what caused their pain and what's going to be done to fix it. Ask the parents or caregivers advice about what's going to distract them to best, and maybe nothing. Maybe they're so in tuned on what's going on that they want to pay attention. So kids at this age understand the differences between physical and emotional. They get it. We may have to explain a lot more than what we think we do, but they know what's going on. Kids 13 to 18, most adolescents are able to think abstractly, participate in decisions making. Technically, they're still a minor, so a parent has to make the decision for them, but you cannot deny them treatment or transportation to the hospital because you're waiting on a parent. They do know the difference between right and wrong at this point. They know it was wrong of them to steal the car. They know it was wrong of them to cut themselves. They get that. So you have physical and similar to adults, but they are still kids at the emotional level. So remember that. Gradually shift from relying on family to more of the friends side for psychological support because friends to them at this age is very, very important. They start to have this right here. Interest in romantic relationships begin. Yeah, sure. So we know here comes the trouble for us all as parents. Puberty. Whew. They all very, very concerned about their body at this point, what it looks like, how it looks. Why do I have this? Why do I have that? Why is there so much hair? Oh my God. It's just, we know as adults, but as kids, poor things, they don't get it and they don't understand why. Um, they may really don't like being observed during procedures that have strong feelings about privacy. They may not be in tune with showing you their stomachs or their legs. Maybe they have an injury to that, and they just because it's very personal for them. Kids still they know fear, they know danger, but they feel like they're indestructible. They feel like they can go without having to worry about that, oh, I'm going to die from that. They just don't know. Mood swings are very big at this age. They're talking about depression, ill and injuredness. They may act younger than they are at the age when they do get injured. They resort back to being a small child. That's okay. I mean, that's workable. We can work through that. So don't just think that that's a bad thing. So when you assess these kids, provide them for information that they request. If they ask questions, answer their questions. Provide choices while leading guidance. And at this age too, you want to get an EMT, paramedic, or a care provider that's the same age or same sex, if possible, for them to make them feel a little bit more comfortable. That's just the best way I can put it. So you're working on assessments here. Or you want to allow the adolescents to speak openly, talk to you, ask their questions, and make sure that you address those questions. Don't talk to them because that's not what the parent asked. No. Some of these risks can ultimately facilitate the development and judgment and shape their independency as an adult. So remember that when you're answering them, because you're at the age or they're at the age where these long-term effects of how they perceive EMS and healthcare and all that may be taken wrongly. Risk can also result in unintentional trauma, drugs, alcohol abuse. All these things can take part at this age because we as providers didn't take the time like we should have to make them feel best with themselves in this incident. So female patients, we we don't want everyone to think about this, but their childbearing age. They are at the age to where we have to assume that they may be pregnant. They don't may not want their parents to know that they are um, sexually active, but it is unfortunately what it is. If you try to interview this adolescent without the caregiver present, and if you suspect she's withholding information, ask that caregiver, parent. Once you get them in the back of the truck, can ask more questions and explain necessary procedures in advance, man. If you got to start an IV, tell them. Don't surprise them. You got to poke their finger. Tell them. It's gonna be hard to distract them. Sometimes they may talk about some things which will distract them, but they're very in tune to things. So doing that at this point is not going to be very easy at all. So trying to read something else. All right. So you must understand the difference between children and adults. This is going to change how we treat them. So watch right here. So look right here at this picture. It's little. Look at the difference in the chest size. The nasal cavities is different. The mouth size is different. Well, right there. So it says pediatric airway is smaller, the lungs are smaller, the heart is higher in the chest. So all these are going to affect every little thing that happens when they breathe. All right, so the glottic opening is higher. We know that, and it's positioned more anteriorly, which is in the back of the neck. But it does. I don't know about being non-existent. As children develop, the neck gets proportionally larger as the vocal cords and epiglottis achieve anatomically correct position. It just got to grow and get some space. Got to move to its new homes. Basically, it's got to do. So here's the occiput is larger and rounder, which requires more carefully positioning the airway. So if you have to put an oral adjunct king airway, be very cautious because you could damage them for a long, long time. So the tongue is relatively to the size of the mouth. It's gonna. I'm not gonna say, oh, it's gonna. They're gonna have small tongues. Well, they are small, so it's gonna be small. But it's for the size of them, pretty good to go. So the long, floppy, U-shaped epiglottis in an infant and toddler is very large compared to an adult. Rings of cartilage in the trachea are less developed, and they're going to be easier to collapse in the neck if the neck is flexed or it's hyperextended. The upper airway is a narrowing, funnily shaped compared to the cylinder shape. Look right here, see the picture? It's a funnel, and see right here, here's our difference. It's a cylinder, it comes through here. So there's a little bit more when they start growing, getting bigger. That's that's part of the parts that grow better. Airway is more easily obstructed. Uh, Obviously, y'all can guess why. Smaller. Uh, Sorry, I had to spit something out. Our respiratory rate's gonna start changing. 12 to 20 is gonna start being normal for them. Um, Respiratory rate for a newborn, 30 to 60. Um, this is when they start changing. You'll notice that they'll have the same vital signs as adults when they get into the preteen age. The higher demand for combined with a smaller oxygen reserve increase in risk of hypothermia, hypoxia. Just because they little, they still need a lot of oxygen. They need that reserve. They need the ability to breathe more oxygen. So again, we're going to want to supply them supplemental oxygen as much as we can. The anatomy of the airway is different. Imagine that. We knew that. I'm pretty sure we did. You must use caution when applying the straps of a spinal mobilization device because it can hinder the tidal volume. You got to be able to breathe. You don't want to go super, super tight. Anything that places pressure on the abdomen of a young child can block movement of the diaphragm because they're still using accessory muscles. They've got to be careful because their respiratory compromise is going to dictate how we go forth in our treatment. That we know that when we get to these certain points that our treatments are going to be more respiratory driven. So we want to keep things off their abdomen and their stomach area. So gastric distension can interfere with movement of the diaphragm, which we know that because they're muscle breathers. Less air is exchanged with each breath, so detection of poor circulation will help us on the absence of breath sounds. It's going to be harder to detect in that point, so we have to make sure we stay on top of that and check their respiratory rates and their tidal volume, minute volume. We want to know that it's adequate. They were breathing fine just a few minutes ago before we put them on this backboard. What caused it? Well, maybe your center abdominal strap is causing that pain. So, or maybe just the displacement of the respirations. So you got to check on that. Here, so the importance to know the normal pulse ranges. An infant's heart can beat at minimum 160 times a minute. That is the only method to compensate for decreased perfusion. Children are able to compensate for decreased perfusion by constricting the vessels of the skin. Man, it's like a cool little bitty computer that's running and working and have everything going, and it's like, whoop, there it goes. Now the skin's down. We're gonna work on our blood flow and all that. It's pretty freaking cool, y'all. Signs of vasoconstriction, they're gonna change. You'll have a weak distal pulse. They're gonna compensate fast. It's gonna be hard to treat them if we don't pay attention to what's going on because they're gonna compensate so freaking fast. When they start getting right there where it says cool hands or feet, you're on the back end of things, y'all. Y'all should have recognized that way sooner. So here's a pulse chart of your age groups. I'm gonna let y'all look at that for just a second while I get something to drink. All right, for the ones that are just listening to me, newborns to 3 months, their pulse should be 85 to 205. 3 months to 2 years should be 100 to 190. 2 to 10 should be 60 to 140. And greater than 10 years old should be 60 to 100. All right, so let's talk about the nervous system. So the nervous system is starting to grow through like the adults. We're starting to get better information. They understand the nerves process is starting to get longer, richer. Things are growing. Compared to the adult nervous system, the pediatric nervous system is immature, but it's growing. It's undeveloped, but it's not protected because the bones are it's not as hard as an adult, so they're a little fragile. You see there that their head to body ratios has gotten a little bit better, um, but they are top heavy. Them poor little brains are they so rich in information that they a little big. They got them big old heads. More prone to head injuries, obviously because of the falls, slip, trips, and falls, or motor vehicle crashes because their head's heavy. Poor things. Their eyes is starting to, the optical region of the head is larger, which increases the movement of the head during a fall. Subarachnoid spaces is relatively smaller. There's not a lot of cushion up in that brain. The brain tissue and cerebral vasculate are fragile and prone to bleeding from shearing forces. So when you get smoked around, there's not enough padding, like they were saying, for you to have that extra, I don't want to say leeway because that's not the right words, but you don't have any extra space for your head to move back and forth and around. So you're going to have more injuries. Um, Matter of fact, like prime example, shaken baby syndrome affects is more severe, obviously as a child versus trying to shake me as an adult because I have room for my brain to move around. Pediatrics, they don't. It's just beat back and forth against that those bony areas, and they deserve to go to prison for what they've done to these babies. Sorry, a little rant. My bad. Get back on topic. All right, so the pediatric brain also requires a lot of oxygen, a lot more. It needs glucose. It needs a lot more, what it says, oxygen and glucose and blood flow than an adult does. This means that the pediatric brain is at risk for a secondary brain damage from hypotension and hypoxia events. I want to make sure y'all understood that. That's very, very important. Spinal cord injuries, you don't hear about more. You don't hear about a lot of broken backs and deficits from back injuries from these kids because they're just. It's more. I call it their elasticity is still there versus when you get older, you're more stiffness. Is how I prove myself. I'm more stiff. So if the cervical spine is injured though, it's more likely to be an injury to a ligament than it is anything else. Like y'all see, uh, if you suspect a neck injury, it's follow your local protocols. But again, maybe you're gonna have more of the sprain than you are gonna have a broken. We know that just because of their age, size, deficiencies, and all that. Excuse me, folks. All right, so the abdominal muscles are less developed in pediatric patients. They don't provide as much protection during a traumatic event. There's no muscles there. They don't have these six packs like I have to protect themselves. Injury, your liver, spleen, and kidneys, they are much larger. So if one gets injured, majority of the time, all of them are going to get injured because of their location, the lack of padding, the lack of security is all going to be there. Because organs are positioned closer to each other, like I said, there is a lot higher risk of organ injury, and that can be caused just by minimal direct pressure due to the injury and the closeness of them. Let's get into the musculoskeletal system. This is where it starts to get fun. All right, so we know they have open growth plates. We've talked about we try our best not for if they do break something, we don't want it near a growth plate because it can it can result into further injuries and damage. The bone length discrepancies can occur if there's broken in a growth plate. Important to immobilize extremities with sprains and strains because they may actually be stress fractures. That's important. We don't want to cause any more damage. So if the poor little guys are complaining, or little girls are complaining of an injury, and it's to a long bone, to an arm, go ahead and split that thing up. Let's splint it to where it needs to be because we need to make sure that we don't cause any other injuries as we're trying to transport them. So the bones of an infant's head are very flexible and soft. We know that from just growth, and everybody's saying, "Oh, be careful around the baby's head. They still got their soft spots." Well, let's not mess with it. There's a reason why it's there. Um, the fontanelles of an infant can be used as an assessment tool. It shows for dehydration. Bulging fontanelles can indicate an increased cranial pressure, and sunken fontanelles can indicate dehydration. That's their soft spots. Gives you an idea. If it's got a bubble, there could be some brain issues in there. Sunken in tells you that there's a dehydration. It's kind of cool little tool, built-in little valve. So the thoracic cage in children is highly elastic. It's got a lot of cartilage there. You're able to palpate it a little bit better. Those the cartilages that are in there are spongy. The ribs and organs are less protected because there's not a lot of fat. I mean, mine's protected a lot better because I'm thick, but not on a baby. These young ones don't have that. All right, so we're going to continue with that one. Maybe. If my computer's not going to work. All right, so going to go over the immune system. Thinner skin and less subcutaneous fat. We know that's going to be issues there. Composition of the skin is thinner and tends to burn. You're going to get a burn a whole lot faster. Higher ratio of body surfaces, area mass can lead to larger fluid and heat loss. So the temperature issue is gonna have problems right there. Seeing size up on a kid. When you get there, so we know things are smaller. We know things react a whole lot faster. They compensate faster. They're going to be more susceptible to trauma. The biggest thing I want you to know is ABCs, life-threatening injuries. We know that. Prepare yourself for this child. No matter what its outcome is, once you see that there's a child there, you need to do your job. We can cry about it, have a mental thought with it later, but we need to do the best thing we can for them at this present moment. I want you to notice the position of the child. What is the MOIs? Where are they located versus how far are they from the vehicle? Where are they located in the vehicle versus what potentially caused the MOI or NOI? Make all these mental notes. I want you to obviously ensure your safety. BSI seen safe. Look for all possibilities of threats that can endanger you as a provider. Unfortunately, the incident has happened. We know that things are going to happen, and we know that we really don't have a way to go back and fix it at the time, but we have to do our best bet. So, you're going to get important information from chief complaints, number of patients, and if we need extra support, call for that. Inspect the physical environment and interactions with caregivers. How is that kid responding? How are they acting? What are they doing? You need a general impression at the same time. We know we're going to document any type of potential trauma that happens. It's just there's so much going on that at some point you're just gonna have to be like, oh, I got to start writing some stuff down. jot it down on some paper, stick it in your pocket, come back to it after a while. Look at your traumatic scenes where the kids, they can't respond to you. It's just, unfortunately, it's a child, and you have to do everything. You need to make sure that you do from a head to toe. If you have to do a head tilt chin lift, you have to unfortunately pronounce this child deceased. You're going to have to realize all these things are traumatic upon everybody. If you get ready to transport them, make sure that you know, just because you put them on a backboard, that they're just not going to fit because it's not a pediatric specific backboard. You need to know that what you're getting into is, you may have some void places. You have to fill those voids before you can transport them and not potentially cause any more harm to this child. So you need to pad the voids, pads the dips in the body, underneath the head and shoulders, to the lower back, even into the knees. Sometimes that's a very effective way of, supplying uh, spinal mobilization. So we'll look at this chart right here. Perform a former drill impression, use pediatric assessment triangle. What is their appearance? What is their work of breathing and circulation to the skin? That, as y'all can read, it takes 30 seconds or less to get your ABCs right there. I need to know that and move rapidly. Pat, so you want to know the appearance. What is their muscle tone and mental status? That's when you rate your appearances, muscle tone and mental status. We know what work of breathing and circulation is. Circulation to the skin. Are they perfusing? That's really what we're looking for right in that area. So appearance. I want to know what their LOC is. How do they interact with me as a stranger to them? Are they able to follow simple commands? Hey, move your hand here. What is their rate of respirations? Uh, you can also evaluate a pediatric patient's level of consciousness by using the AFPU, as it shows right there. But remember, sometimes you may have to do a modified one due to the patient's age. An infant or a child with a normal level of consciousness will act appropriate for his or her age. Now, if you get a 12, 13, 14-year-old that reacts inappropriately, well, why? Are they acting younger? How are they acting? Let's note that, and let's figure out what's going on. Their work of breathing, is it increased? Why is it increased? Do you see abnormal nose airway noise? Do you hear things? Do you see accessory muscles being used? What about the reactions? Sorry. Retractions of intercostal muscles means that they're doing the seesaw method. They're breathing chest out, stomach in, stomach out, chest in. It's like a big seesaw. So are they using those? Do we know any kind of head bobbing, nasal flaring, tapnia, increased heart rate, and as you see, the last one, tripod position. In older children, this position will maximize their effortness, the effectiveness of the airway. They're leaned over. They're increasing the space for them to take deep breaths. That's why they go into this tripod position. That's why we need to know about that, because it tells us that there is a respiratory distress because of them being in that position. So we talk about when cardiac output fails, the body will shunt blood from areas of lesser needed. The skin's going to be your first one, to greater areas such as the brain, heart, and kidneys. Very, very important. Pallor to the skin and mucous membranes may be seen in compensated shock. I always like to check the gums. Sorry, I got coughed up there. If I check a child's, I'm just like, hey, do me a favor, smile. Okay, let me see the top of your teeth, and they'll open their mouth. Or if I have to be able to open their mouth and see their gums, that's not normal. That's going to be signs of anemia or hypoxia. Depends on what their mucous membranes look like. Look at their eyes too. Check their eyes. What color are their eyes? Cyanosis. We know what cyanosis is, and that's going to detect our low level of oxygen. It says a late sign of respiratory failure is going to be very fast and your hands are going to be super full. Never ever wait for cyanosis before delivering oxygen. Always give it prior to what you think. Oh, well, I think they're having trouble breathing. Let's give it to them. All right. From the PAT findings, you need to decide if the patient is stable or not. Do they require rapid transport or can you stay and play? That's what you need to know ASAP. All right. Without obvious life-threatening threatening external hemorrhaging, assess the address. Crap, I can't talk. Assess and address this with circulation, airway, and breathing first, and this includes tourniquets for arterial hemorrhaging from extremities. So in kids, you're going to go circulation, airway, breathing, and the reason why it's turned around is because their blood volume is so low, they lose a lot of blood volume. They cannot compensate. They will stop breathing, heart beating, they will stop it all. If the patient is stable, continue doing the remainder of your assessment, but you need to perform the necessary interventions before you keep going. If you find it, fix it. Keep going, find it, fix it. And you need to know what the transport decisions are going to do. What does the parent want? Where do they want them to go? Okay, now that's not a good facility. Let me take them to this where they have pediatric specifics. If it's a pediatric trauma, you need to transport them to a level 1 trauma center that has full pediatric capabilities. Period. Hands-on ABCs. I need you to assess every single one of these. Airway, breathing, circulation, disabilities, and expose. Can you exposure? Are they exposed to the environments? That's what I need to know. And exposure, do I have to cover them to warm them? I just need to know. All right. Anyway, if they're open and the patient can keep talking to yourself, let's rock on. But if the patient is unresponsive and they're not able to hold their airway, you may just have to do a jaw thrust, head tilt chin lift, if there's no trauma around. If they start spitting up, throwing up blood or vomit, I hope it ain't in my truck. That's the best I can tell you because I don't do smells. You need to suction that out. Have that suction right there ready to go so you can clear that airway because, again, why? It's small. It's going to occlude very fast. So always position the airway in a neutral sniffing position. Please check in your book on page on skill drill 34.1, and it shows you what that position is. It keeps the trachea from, they say kinking, but I mean, you're not going to form I'm not sure how you can form a kink in it unless you just lose all. But anyway, still in that position, it's going to be in the proper alignment that you should have to immobilize the spine. What's it say? Establish where the patient can maintain his or her own airway. That's very, very big because then you know what the status of this patient is, their mental output, their level of consciousness. That's always very helpful is to get them to be able to handle their own airway. Super, super important. That's what we all want anytime we have a patient. So look, listen, and feel. If they're unresponsive, that's your job. Is to start with CPR. If you have to, look, listen, feel. What's going on? Do you feel movement of the chest? Sometimes you're going to have to palpate. Is the chest going up and down? Do they even have adequate respirations to keep going? Belly breathing in infants is considered adequate because of the soft, pliable bones of the chest and the strong muscular diaphragm. Decrease in the respiratory rate is bradypedia, and that is an ominous sign of impending respiratory arrest. If you start to see this right here, you are going to have respiratory arrest, period. Just know you start documenting their respiratory rate is decreasing and you haven't done nothing about it. One, that's neglect. Two, is you haven't done your job to do a full assessment. And three, your patient is fixing to go into respiratory arrest. and now you get into SOL. Circulation. Circulation. Sorry, I don't know where that circularization came from. And it must be determined if the patient has a pulse. You should know that right as you walk up to them. On infants, palpate the brachial pulse or the femoral pulse. And children 1 year or older, palpate the cricoid pulse. Strong cervical pulses usually indicate the child is not hypotensive. It's a big. You want to check a big vein. You're not gonna find a big vein in the arm for a child. All right. So absence of a central pulse indicates that you need to provide CPR. Tachycardia may be early signs of hypoxia or shock. It's less serious as a fever, anxiety, pain, or excitement, but their heart rate is increasing rapidly. Uh, Interpret the pulse with the correct content. Overall, you want to know their history. What did you give them on the PAT? What was their score? Does this go with your primary assessment? You need to be very cautious and pay attention for rapid changes. When hypoxia or shock becomes critical, bradycardia occurs. You are in the late stages. Bradycardia in a pediatric patient often indicates impeding cardiopulmonary arrest. They are dying in your face. Feel the skin for the temperature and the moisture. What is it? Uh, if you check their cap refills where you squeeze their fingers, and it should return to its normal color in less than 2 seconds. If it doesn't, you're in trouble. Period. Not say you isn't personal, but you as your job is just gonna get serious because that baby is decompensating in your face. All right, so we're gonna check for disabilities. Use the APU scale or the pediatric Glasgow Coma scale to assess conscious face. Well, you're gonna give everybody an APU and you're gonna give everybody a GCS, no matter what. You want to check the responsiveness of the pupils, or do they? When I say check them, I want to know, do they constrict after you shine a light in their eyes? Now, you're not going to use your 7 billion candle watt flashlight that you carry in your pocket, but you get a pen light. Does the pupils constrict or not? Pupillary response, it's going to be normal, but the presence of drugs or seizures or hypoxia or brain injury is going to affect that. You want to look for the arms, right and left arm, to move. It says symmetrically, but you want them to move equally. If you say raise your arms and one arm's at a 45 and one's at 90, okay, that's good to me. I can deal with that. When I ask them, can you give me a pain scale? Here's a picture. Look at this. Tell me what your pain is. I mean, if they're screaming their guts out, pretty sure that's high. I mean, could be that they're scared, but they're pretty close. Most, like it says on the third one or fourth one, pain is present with most injuries. The kids are going to let you know. Inadequate treatment of the pain is going to have an adverse effect on the pediatric patient and the family. So remember, you're not trying to fix it or make it any better. They will remember that. So when you assess the pain, remember their age. If they're infant, child, school age kids, remember to use the faces. That's going to help you out a whole bunch. Sorry, I keep moving my mouse on my screen. It's going to help you assess their pain level. And that being the case, man, we got to treat them. We got to know what their pain level is. All right, so exposures. I need you to do a hands-on assessment. You're gonna you may have to expose them, but I need to see the chest movement. I need to see if there's any circulation problems. Is there any blood anywhere? Is there anything that's impaling them? Now, obviously the bullet right there. All right, so I had to step away, so I don't remember where I was at. But we'll go here. So pediatrics are very prone to getting hypothermia. So when you get to these kids and you start exposing things to check them, to assess them, go through the assessment, make sure you understand that you have to keep them warm and covered. But when you need to uncover them, you can assess them, that they can lose up to 50% of their body warmth by their head. So you gotta make sure you keep their head covered. That's the reason why we always, the kids and the babies always have these cute little hats on, because we need to make sure that they don't lose the heat, because they're gonna radiate heat from the top of their head. So during assessments, like I keep saying, remember it. Um, so keep that in the back of your mind when you're assessing these babies. All right, transports. The best thing I can tell you is have a good plan. Have it in your mind what facility in the area that takes and cares for pediatrics, and what's the best route of travel, that from where you're at to this facility. All right. So remember, if it's an MOI from a height equal or greater than the height of this pediatric patient, they're gonna land head first because their heads are always bigger. Complete a good history. Do a If you notice any physical abnormalities, make sure you note that. Either you can fix it if you feel that it's a life-threatening issue. Be on the lookout for potential serious anatomic abnormalities. Check for those. If they say, hey, I'm hurting here, right here, and it's a significant pain, and they're rating it on a high scale or of the frown face, that you take very good, assessments to that area. Abnormal level of consciousness may be signs of symptom of shock. Don't forget to treat your patients. Always make sure that you can consider ALS intervention. If ALS comes around, what your local protocols say. The transport time. If the pediatric patient's condition is urgent, then initiate immediate transportation to the closest facility. Special facilities such as trauma centers or children's hospitals have the staff, the equipment, everything that is going to be able to provide the highest level of care to all pediatric patients. The most appropriate facility may not always be the closest, but ask yourself a question. Can I deliver this pediatric patient to the most appropriate facility without risking or delaying the treatment to the patient? If your answer is no, transport your patient to the closest facility and let medical intervention start early. All right, so if they are 40 pounds or less, they must be transported in a car seat. That's what they're wanting us to tell you. May not happen that way, but that's what they want me to tell you, so you can take a test on it. So the seat is chosen if they're in a car seat and involved in a motor vehicle collision. You know that car seat has to be replaced. It's a significant enough one. That car seat must be replaced because there may be unforeseen damages to the plastic in there. You can secure these car seats to the stretcher. You can use the stretcher straps that come on your stretcher already to secure it. You can also tighten these children in to these car seats by the normal straps if they're not endangered or anything like that, just to go get them checked out so they're safer for transportation. Always follow. I'm not going to sit there and ask you to read what the manufacturer's instruction says or where to put them for. But if you got to put them in a spine mobilization, a KED would be very beneficial for that. It will help them hold them still, keep them immobilized, and they won't be wiggling around everywhere. If patients in cardiac arrest use a device that can be secured to the stretcher, like a KED would be perfect. Pediatric patient, you should use the pediatric patient's own car seat if possible, and the goal is to secure the patient to protect the pediatric patient transport in the ambulance. Always keep their safety at the utmost. So history depends on their age. Are we able to gain a good history. Maybe if it's coming from a school, the school is able to provide some information. If it's not, and we're unknown of the patient's, caregiver, parent, or anything like that, we may just have to go with what we got and make our own up. You can question the patient, but remember, they may not be able to tell you. One is because they're scared and they just don't know you, and they're scared that they're going to get in more trouble because of their injuries. So build that patient rapport and treat your patient to the best of the ability with what history that you do have, but try to get the best one. If we're able to ask questions and we're able to get good answers, here's some of the questions we need to know. What is the nature of illness or mechanism of injury? Length of sickness or injury. How long have they been sick and why are you calling me now? What is different from then versus now? Is there fever? What led up to this? Effects of illness or injury on the behavior, patient's activity level, and recent eating, drinks, or urine output. This bottom one is super, super important because I need to know what their nutrition. Are they malnourished, or are they being deprived, or what's going on? I need to have those answers prior to leaving. So here's some other ones that are very important because can tell you some things of shock or potential injuries. Has there been change in bowel? Have they been pooping or have they been peeing a lot? I need to know. Are they vomiting? Have they been diarrhea? Do they have abdominal pain? Do they have any rashes? Look for these rashes on the chest, the abdomen, and the back. Look around the neck. Have them stick their tongue out. Do you see any, thrush that's maybe in the mouth? If the patient's caregiver, let's say it's a daycare, and they're not able to send somebody, you need as much information as you can so that the hospital may be able to call them back and ask some more questions. But then myself is going, why the hell am I not sending nobody? Because that's this baby's caregiver. So that should, put up a red flag to you also. So your sample OPQRST is based on the development stage of the kid. I don't really know how else to tell you that. On a secondary assessment, and assess the entire body, even if they're unresponsive or they are responsive, and always look for hidden illnesses or injuries. Use your DCAP BTLS, like we've said multiple times before. This will help you identify problems that were not as obvious during the primary assessment, but over time, the persisting signs and some of the symptoms may be more apparent. It's telling you to use the DCAP BTLS mnemonic. So as you go and assess all these different body parts, it will help you. During the focused assessment, it should be performed on a pediatric patient that does not have life-threatening illnesses or injuries. You need to make sure that if they do have any of these, you need to focus. You may not make it to your secondary assessment. Your focused assessment is still going to be ongoing, and you're going to be rapidly treating that because you don't need them to digress or get worse. So your physical exams, where we tell you to begin with, it says right there, start at the feet, end at the head. That gets you like I keep saying, it builds your rapport with these kids, and it gives you the ability to gain some trust that these kids are giving you, and the ability to say, hey, look, I'm not bad. I'm here to help you. Work with me. Hey, if I touch you on your right toe, does it hurt anywhere? And you may tickle them if they're just feeling sick, or you don't want to cause any more harm, but you need to build that I'm a good guy. All right, so physical exams, we're going to go into the secondaries. What we kind of want to do is just start. We don't want to automatically assume that every kid's has been abused, but we need to look for the bruising, the swelling, and the hematosis. In younger patients, the large head proportion to the rest of the body, so check out, make sure that they don't have a whole lot of bruising there. Significant blood loss can occur between the skull and scalp, so don't forget about that. A tense or a bulging fontanel in the upright non-crying infant suggests an elevated intracranial pressure caused by meningitis or intracranial bleeding. So don't forget that. So a sunken one causes from dehydration. All right. So young infants are obligate to nose breathers. So nasal congestions can cause some distress in breathing there. They may just need like the blue booger sucker that you can see that's in the OB kit. That may help. But just if they have it, cool, let's use theirs. Because as soon as you open that OB kit, in about 30 minutes you're gonna need it. So just remember that if they have one, let's take that with you and let's just use theirs. Ears, ear drainage. We're gonna look if we see any type of fluid that's coming out their ears. Let's put it on a 4x4, see if it creates that halo effect. And you may see battle signs. It's just from a beaten or abused child. Look for pus. Do they have like ear drainage? What color is it? Is it from a busted eardrum? I don't know. Let's look. Um, Look for the activity of bleeding and loose teeth. Maybe they were punched. Maybe they got pushed down. I'm not real sure why I'm saying you note the smell of the breath. I can't really tell you on that one, y'all. I'm sorry. The neck. Again, we're looking for bruisings. Um, if the patient can't move their neck due to high fever, this may indicate some meningitis. That's a bacterial infection. Chest, again, we've already talked about that. The bruises, rashes, or potential lacerations. If they notice to have tenderness around the ribs, let's see why. I hate to say that maybe, this kid may be a BMX racer or a motocross and they just didn't tell you and they had a bad wreck. Well, that could indicate why that they had bruised ribs. So I can get that. Back is all of the same thing. On the abdomen distension, uh, that'll tell you for any type of abdominal injuries, some swelling. If they're guarding the area and they don't want you to check it, why? Need to know why they are not allowing you. Does it hurt? Are they trying to hide something? Or is it just super painful that they don't want anybody to touch at all? So the symmetry of the movement of the extremities, can they move their arms compared together? Are they able to up and down? Do they have the skin color, temp, and condition? Is it good? Is it bad? Is there noticed any swelling? Um, can they move their elbows, their knees? Can they, wiggle their fingers right? That's a good assessment of checking that. Vital signs, make sure that their heart rate, is it's intact with what your charts are saying they're supposed to be. But if they're under the age of 3, do not check their blood pressure, okay? Because first off, you're not going to get a good one, but you don't want to cause any more interosseous trouble. So let's just not do that. Let's just check their pulse, and we have these cool little deals to do on their pulse ox that'll help us out there. You So here's another problem is if the cuff is too small, you may get a super high reading, and then the same thing, if it's too big, you're gonna get a very low reading too. So you make sure that if you have to do a pulse or a blood pressure in these ages, you get one that fits. An adult is not the use all care all. Um, so here's a formula to get it for your potential blood pressures, but I've never done it. So if your blood pressure is 70, you want to take 2 times the child's years and age, then you add that together, and that gives you your systolic blood pressure. All right, okay. But um, I don't ever do it that way. Your respirations, at least count respirations for at least 30 seconds and then double that number. Same thing we've done before. If you do your pulse on an adult or of good childbearing age, you check their pulse for 30 seconds times 2. No big deal. Good to go. Um, you at least, what's that say? Assess the pulse rate by counting at least 1 minute. Nothing quantity, noting quality and regularity. Okay, if you want to do it for the full minute, that's fine. Always remember when you go to assess them, use the warm stethoscope, warm it up. Don't pull it out of the freezer and stick it on their chest because they're gonna react differently to that, and you shouldn't do that anyway. A pulse oximeter is a huge valuable tool, specifically when somebody's in respiratory arrest, because it gives you what you need to know. Because you're not going to know. Well, I think he's breathing 47 times a minute with that 80%. Well, you're just guessing. You have no idea. Even though we've taught you with your skills and abilities and learn how to check manual blood pressure and pulses, let's use the tools that are there. Those tools are made for specific reasons. I'm okay with using them. I don't know about y'all, but I'm going to use my tools. All right. So you're going to reassess the same thing as an adult, 5 and 10. I know it says 15. I guess I should change that in the slides. And continuously watch your patient. If this patient is in need of care of all the time, then you provide care all the way to the hospital. Don't worry about your secondary assessment. Continue with your primary assessment and treat that baby with the utmost ability that you have. If you're able to get ALS services in a route, they may have you just ride back there with them because you've already built the trust and care for this child, and they may transfer this off to a higher level ALS care, unless it's like a sprint truck or something like that. All right, so interventions, make sure you tell these kids what's going on. Let them know that you're going to be doing this. Calming measures, your face, your demeanor, your overall impression is what is going to dictate this kid, okay? So if you, now here, remember, you're not given medications, but when you go to give like a nebulizer, explain what's going to happen. This cool little mist is going to come out, and you're going to take a deep breath. Now, where it says right here, whoops, right there, wrong screen, my bad. So now that we're on the same page. So a kid that is well versed in their medical condition, listen to that child, because I promise you they know what they're talking about. And if you don't believe them, let them make a fool out of you. I'm just saying I've learned that. So everything that you've had this entire time, you want to take all that information, hand it off to the ER, hand it off every bit of information so they're not going back and trying to build a whole nother blanket exam. Whew. Respiratory emergencies. All right, so any respiratory emergency in a child, pediatric, can potentially lead up to cardiac arrest. If you don't recognize this in early stages, they're going to die. I'm sorry to say it that way. So during respiratory distress, the pediatric patient is going to be working harder to breathe and is going to go into respiratory failure if you do not do your job. Some of the things you can look for is they start being combative, start fighting you over everything. They're not resting. They're just all over the place. Sir, ma'am, baby, I need you to sit still. And their anxiety is through the roof because they know they're not happy. Something's wrong, and they don't know how to tell you. Here are some signs that you're going to see for these increased workload. Sorry, nasal flaring, abnormal breath sounds, accessory muscles, and them being in the tripod position. That is all of those right there should tell you that you need to work fast, super fast. So their efforts of so when they go into respiratory failure, their efforts to breathe rapidly decrease. I'm not sure if I need to explain what the second one says. Their chest rises less with inspiration because their body is weak. They don't have any more glucose stored into their body, like number 3 saying. Body has used up all the valuable energy stores and cannot continue to support extra work of breathing. Their tank is on empty and it's shutting down because there's no more glucose storing. If you don't do anything, you're going to notice cyanosis of the lips. That is 100% neglect. You have allowed this pediatric patient to die in front of you. You have to treat these babies. All right. So if changes in behavior will also occur
until the pediatric patient demonstrates an altered level of consciousness, because their body has running on they're hypoxic. They ain't got nothing. The lack of oxygen becomes more serious, and the heart muscles become hypoxic, and everything just starts to slow down. When that slows down, you must be able to start doing CPR immediately. And this is going to quickly progress into cardiopulmonary arrest. These babies are done. They're dying. Respiratory failure does not always mean that there is an airway obstruction. And the condition, it may indicate trauma, nervous system problems, dehydration, or metabolic disturbances. A pediatric patient condition can progress from respiratory stress to failure at any time. You must assess these pediatric patients very frequently. A child or infant in respiratory distress needs supplemental oxygen that you have, and it's easy to give them. For infants and children, if possible, and they are going into respiratory failure, you need to start with a BVM at 100% of oxygen, which means you need to bag them, and it needs to be hooked up to portable O2. Allow this patient to remain in a comfortable position. Usually that is on a top of a caregiver, but remember, you may be trying to get this caregiver to chill the hell out and calm down, because now you're going to be treating two patients than one. All right, here are some common objects that can fit in the mouth and become airway obstructions. I'm sure we've seen more that are out there. Anytime you see blood or vomit, we know there's a potential cause for severe airway obstructions. Some infections, including pneumonia, croup, epiglottitis, and bacterial tracheitis, that's a big one for me, can also cause airway obstructions. Because with croup and epiglottitis, oh, no, never mind, there's a picture coming up. Here, let's look at that. All right, so you see right here, the swollen epiglottitis, so that's closing the airway, and they constantly feel like they're choking. See how small it is right here? Because here's the airway coming to the back. That's the stomach going down. They're gonna I feel like they're dying, because they're always constantly, I can't swallow. I feel like my throat's closing up. And that's what's happening. They're losing part of their airway. So obstructions may be partial or complete. Stridor is usually caused by swelling to the area surrounding the vocal cords and the upper airway obstructions. Signs and symptoms of lower airway obstruction include wheezing and/or crackles. If anybody want to know what it sounds like, you can YouTube breath sounds. Type in wheezing or crackling breath sounds, and it'll give you a really good idea of what they sound like as you're getting into this field and you start listening to kids, and you want to know what they sound like even for adults. There you go. Best way to listen to breath sounds in a pediatric patient is to listen to both sides of the chest at the armpit level with a warm stethoscope. Don't forget that, y'all. All right, so you want to immediately start treating this. This is a life or death situation, because now that their airway is obstructed, they have no way to get air in them. If the patient is conscious and coughing, you need a coughingly forcefully, and someone saw him or her ingest a foreign object, encourage the child to cough to clear the airway. If it doesn't come out, you need to give high flow O2. I always transport them in a position of comfort. If they need to be sitting at 90 degrees, transport them secure to the stretcher at 90 degrees. If you see signs and symptoms of a severe air obstruction, attempt to clear it. Here are some signs. They have no sounds of an ineffective cough, inability to speak or cry, increase in respiratory difficulty with stridor, cyanosis of the lips, and loss of consciousness is the last resort, unfortunately. All right. If an infant is conscious with a complete airway obstruction, perform 5 back blows followed by chest thrusts. And you should have learned that in your basic CPR first aid. Position the infant face down on your forearm, supporting the jaw and head with your hand, and slap the back forcefully 5 times with the heel of your hand. Now, I'm not trying to put my heel of my hand to the front of their chest now. Y'all remember that. But at the same time, as I'm not trying to give them this warm and fuzzy hug, I need to make sure that this is forceful enough. You need to repeat this process until it comes out or they go unconscious. If they, when you go to, what's it say? If the airway does not clear, flip the child onto his or her back and perform up to 5 chest thrusts in the same manner you would give CPR. Because what you're trying to do is increase that the pressure in the chest to push that object out. That's what you're trying to do. If a child is conscious with the complete airway obstruction, you can use a Heimlich maneuver. You may have to get down to that kid's height. Don't pick them up and try to suspend them over the air, over the ground, in case you fall. You are going to cause more damage too. All right, use head tilt, chin lift, finger sweep. Make sure if you do that of an unconscious patient that you protect their keep their teeth from falling back on your fingers. If you can use a bite block to potentially sweep it, put them down, put their jaw. If you see it in the center of their mouth, you need to rake it to one side or the other, whichever one is closest to the ground. Chest compressions are recommended to relieve a severe airway obstruction in an unconscious patient, which we know that. Right there, it says we're trying to increase the pressure in the chest, creating an artificial cough. That's what we're trying. Now, I'm not sure it's going to work, but all right. So asthma, I'm pretty sure a bunch of you already know about asthma. Either you may have it or know somebody close to you that does have it. But what it does is the bronchioles within the body, they absorbed more mucus than anything else, and it's not allowing the oxygen to oxygenate the bronchioles. So they're full, they're blocked off, and they're not being able to oxygenate. So they get that sound where they don't breathe real well. So according to CDC, and of course this is CDC, so I'm not a big CDC fan. 10% of children have asthma, and I think this is last year's. 285 of them died from asthma. That's a lot. I mean, one child death is too many in my eyes. But there are certain things that trigger asthma attacks. Anxiety, exercise, smoke, upper respiratory infections can cause them very bad. It says exposure to cold air or smoke. A lot of times cold air will help. Heat sometimes can do it. Signs and symptoms. Characterized wheezing as a patient attempts to exhale through partially obstructed lower airway passages. Sorry. In other cases, these airways are completely blocked and no air movement is heard at all. You will start to notice cyanosis around the lips early in these patients because they're already at a deficit, they're already down on it because they have asthma. They live with it at all times, so they already know that their bronchioles are not receiving air at 100% level like majority of us are. But so these poor children and adults know that they quickly have that their inhalers around them, and they're much more susceptible for cardiac arrest, or respiratory arrest than anybody else. Go. It's not clicking. All right, so the treatments. Position of comfort, high flow O2, bronchodilator is needed. Now, as a basic level, you can't provide these things. But I do recommend that you check with your local provider, whatever your protocol says that you can do. But they need ALS. They need to get this albuterol. They need to get the Provenal. They need this in their system, which is going to open the area, the bronchioles that are closed. But you're gonna so I'm not real sure. We're talking about assist ventilations, slow gentle breaths. Maybe they were trying to get you to add more pressure to the chest, but at the same time as I'm not trying to overventilate them. But if you can, a high flow non-rebreather is your best option right there. Prolonged asthma attack may progress into status asthmatis, which is a 100% true emergency. May have a higher chance of dying. That's why ALS needs to be there quickly. Rapid transport, we know that. We need to get them quick and safe and to a facility that we can potentially stop this. Manage airway aggressively, administer oxygen transport. ALS, the reason why we want ALS is so we can get them that dilator, the bronchodilator that we want. We need that out there. Sorry. So we need to hurry up and get ALS to them. So this is the leading cause of everything for children to. There we go. Sorry. According to the WHO, which is the World Health Organization, pneumonia is the leading cause of death in over 2 million children worldwide annually. So this is off. It's, as you can see there, pneumonia is generally a term that refers to an infection to the lungs. You can get it normally. You can get it as a secondary infection. It can be from a chemical ingestion. Children with disease-causing immunodeficiencies are at risk for developing pneumonia. They are higher during the winter months than they are summer months for children to get pneumonia. They normally are rapid breathing. They are freaking out a little bit because obviously they're having trouble breathing. You get your nasal flaring, your tachypnea, your hypothermia, and breath sounds are going to be diminished because of the lung infection that's already prior, and it's gotten a whole lot worse, unfortunately. All right, let's get back to this. All right, so I'm a pediatric patient. Sorry, I got off screen on my big one. I got to change it back. All right, so the primary treatment will be supportive on pneumonias. You're going to monitor their breathing, make sure what their level is, check their status. Like I said before, y'all have read it, they're going to decompensate pretty fast. And you can't diagnose them in the field with pneumonia. They're going to get back to the hospital for that. We're good. We just ain't that good in the field. All right. Croup is an infection of the airway that below the level of the vocal cords caused by a virus. So the way I remember croup and virus have the same exact letters. It's just, I know it's virus, croup. It's kind of the way I remember that. Typically seen in children from the ages of 3 months to 6 months to 3 years. It helped if I better read my own notes. You can very easily pass this amongst kids, back and forth between each other. That's why you want to try to separate them, or they're sent home from child daycare, or separate them from their siblings when they're both that age. So the disease starts with a cold, cough, low-grade fever, and that's going to progressively get worse over 2 days. As you see there, the hallmark sign of croup, a stridor, or a seal barking cough, which you know that, and it's like, oh. So you're like, uh-oh, that's a problem. Best we can do there is humidified oxygen in the field. You're not gonna give them any type of breathing treatment because it's just not gonna work. It potentially can make them worse because now you're just trying to overfill those the bronchioles instead of trying to treat it. So a bacterial infection is epiglottitis. That is a severe infection above the vocal cords. All right. So since the development of a vaccine against one organism that causes epiglottitis, the incidence of this disease has gone down drastically. In preschool and school-age children, the epiglottitis can swell to 2 to 3 times its normal size. Oh, that's a big, oh, that's got to be painful. All right, children with this infection look sick. They look like crap. They're going to tell you that they just don't feel good. And when you go to find them or take care of them or treat them, they're going to be in that tripod position because they're trying to increase that space in their airway. They're trying to make things bigger so they can have more space, and they just don't feel good. That's what they're going to tell you, is they just feel like crap, okay? All right, so bronchiolitis. Oh, sorry, I got to sneeze. Hang on. Bless me. All right, so this is a viral illness. Most newborns get it. You see right there, it's often caused by RSV, and that's respiratory. I ain't gonna try to pronounce that. I'm gonna make a fool of myself. You already know I'm crazy anyway. So RSV is very contagious. Okay, make sure you know that. You need to clean surfaces. You need to wipe things down. If there's anybody else in the home, that needs to be separated. And they spread while the kids are. So if you can catch it fast and they have RSV, they will empty out a child daycare in a split second. Let's see. It's often more common in premature infants because they're not. They're not. I'm not gonna say they're not developed correct. And that's not what I mean is, but their development was delayed, so that's gonna make it more worse for them to get the bronchiolitis. Oftentimes, males are more common to this than females. Yes, we know y'all are special ladies. You get it. It's written right here in paperwork. So, again, this is going to see your early spring, winter illness. Bronchioles become inflamed and they swell with mucus. Does sound like another one that we just went off. So it could go into pneumonia. And you're going to look for dehydration, shortness of breath, and a high spike of fever. It's going to be pretty quick spike too. The best thing we can do is just provide oxygen and calming measures, giving them calming sensations, trying to get them to, take some slow, deep breaths and put them in the position that's comfort to them, and don't freak out. Allow that child to basically dictate the treatment upon their. I'm not gonna say we're gonna tell them no, you can't give me oxygen, but allow them just to dictate it. Be like, hey, I want to put you on some oxygen. Do you mind holding this for me? And allow them to hold it. Yes, it says consider ALS backup, but this can turn kind of crappy pretty quick. So just know that be cautious be cautious on calling them too late because it can be turned pretty bad. All right, bursitis is also the whooping cough. That is a communicable disease caused by a bacterium, and that spreads just like COVID and the flu and everything else. It's a respiratory droplets. That's the reason why we say cover your mouth when you sneeze, or take your 6 feet of distance between people. That's why. Now it is not as common in the U.S. as it is elsewhere, but and it says as a result of vaccinations, this potentially dead disease is less common in the U.S. because it's required to get that for school age kids. Some of your typical signs is common to the cold, coughing, sneezing, and runny nose. As the disease progresses, the coughing becomes more severe and is characterized by the distinct whoop sound heard during inspirations. Infants infected with bursitis may develop pneumonia or respiratory failure. These babies are sick. Don't forget that. Not like sick. They very sick. Like, bruh, you might want to get to the hospital because they're gonna be stuck there. All right. So treating of these patients, they're gonna make sure that you keep their airway open. Give them as much high flow O2. Take your standard precautions. You do want to put a mask and not say goggles, but you want to have any type of droplet protection. If you feel like you need a gown, that's fine. but know that you just need to use personal hygiene. Also, wash your hands. Like we have a joke around here: it's just wash your damn hands. A lot of these diseases can stop that way, but people in general are just nasty. So nasty, nasty, nasty. All right, we're going to talk about airway adjuncts. We know what an airway adjunct is because we've gone through the other classes, but these are your OPAs and your NPAs. A bite block obviously is a little device that it's going to be shoved between the top teeth and the bottom teeth that keeps them from biting down and stopping the adjunct that's in the mouth. And then we have BVMs. OPAs, I'm not really going to go deep into this because we've discussed that. We've gone over how to measure them. We know between the difference between OPAs and NPAs. There are different sizes for pediatrics, and that's what you need to know, that you need to get the pediatrics out and measure just so you know this is the right one if I have to use it. This You only want to do this for those poor babies that are unconscious because they not going to tolerate that shit while they awake. I can promise you. NPAs, I hate when they say they're usually tolerated. I've NPA'd myself. It's not the worst thing I've ever had done in my life, but it's very not comfortable. Okay. So they don't want you using these on any child under the age of 1 because of the nasal passage, and it's short. You could cause some more damage in there just by trying to shove it in. So keep that in mind, as you don't want to use it on anybody else. And it should not be used if there is a nasal obstruction or head trauma for kids. It's telling you that skill drill 34-3 breaks it down a little bit, kind of gives you some better understandings. So here's some potential problems from an NPA. They say that an airway with a small diameter may become obstructed by mucus, blood, vomit, or the soft tissues of the pharynx. If the airway is too long, it may stimulate the vagus nerve, and slow the heart rate, or enter the esophagus, causing gastric distension. So that second bullet is very important because it can add stress, and we don't want to add stress. We want to make sure that their care is the best. We want to give them the best care of their world. NPA should not be used when the pediatric patient has facial trauma because the airway, it might tear soft tissues and it's caused bleeding into the airway. That's the biggest reason why we don't want to use it there. Some options for kids. It says in treating infants and children who require more than the usual 21% is found in room air, you have several options. We can do blow by, which just means we're just laying it by them. We don't have to attach it to we don't have to put the elastic string over them. We just lay it by their face and let them go on for there. You can use the nasal cannulas, non-rebreathers, and if worst case scenario, you can bag them, and that gives them 100% of oxygen. Non-rebreather mask, nasal cannula, or simple face mask indicates so they have their specific size. So make sure when you pull it out, it's the right size and it's a pediatric size. Children with respirations are fewer than 12 breaths a minute and more than 60 minutes a minute as an inadequate tidal volume, and they should be given assisted ventilations. Remember that, folks, that you need to provide. If they're not breathing at least 60 times a minute, that you need to bag them. All right, so you got your blow-by method. That is not the most appropriate one. I'm not going to say that it is not usable. We can use that, but it doesn't provide a high flow of concentration. You're just breathing. It's trying to build up the courage to attach it to their face. Place the oxygen tubing through a small hole in the bottom of an 8-ounce cup, or something that they're familiar with. Connect the tubing and oxygen, and only put it about 6 liters a minute. I like using a non-rebreather and just laying it close to them and letting them on their own stick their face in to take a deep breath and pull back. It builds. It takes a little bit longer, but it does work. Nasal cannulas, again, also. Here's a picture of the cup that they're talking about. It's not as suffocating for the kids, and they don't feel like they're being, bound. No, we can't do that to y'all. Y'all have to suck it up and put on the non-rebreather one or nasal cannula when it's time to use the oxygen delivery on yourself. So the non-rebreather mask, we get about 90% of the oxygen by that. Uh, 10 to 15 liters a minute. Be cautious of that. I know it's not going to change, but sometimes it's a little over powerful for the kids, and you'll notice they do have a little bit of trouble from that. But that's okay. You can adjust that pressure. That's why I give you a range from 10 to 15. Bag valve mask, we all know about that. Here's a better picture. The the non-rebreather versus the bag valve mask. And the biggest thing is make sure all these cords, see the hose of these tubings are all plugged up into supplemental oxygen. Otherwise, this bag wouldn't be inflated and that bag wouldn't be inflated. And those bags are for reasons. We got to have those. That's the way that we get supplemental oxygen delivered. You have your two-person big VM. One person holds the mask down, the other one breathes. Just kind of same thing as CPR. All right, so I'm not real sure to go over this because you are required to have CPR. So I don't feel like I'm going to dive off into that. Shock. What do they want me to say? Shock is a condition that develops when the circulatory system is unable to deliver the correct amount of blood. It results in organ failure. It's compensated shock is an early stage of shock when the body can still compensate for blood loss. Decompensated shock is later in stage, and you'll notice that's when the blood pressure starts falling rapidly. Pediatric patients are most common causes. You can see right there, trauma, especially if there's an abdominal wound, dehydration, infection, neurologic injury, obviously as a subject to head trauma. Common causes, allergic reactions, disease of the heart, collapsed lung, tension pneumothorax, cardiac tamponade, or bursitis. Shock is shock is shock. It's just going to happen a lot more rapidly in children. So once we've gone over shock in general, it's the same thing that can affect in adults. It's just, I know I keep saying shock is shock is shock, but it's the same thing just on a smaller scale. Signs of shock in kids, you have your tachycardia, increased heart rate, poor cap refill, and it is crappy, and it's less than 2 seconds. You notice a big mental change. If they start not able to answer your questions correctly, or blah, 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 and they just, hey, what is today? Purple. I want to be here. I want to be back on the beach. You picked them up from their house. Just weird things like that. If there's obvious life-threatening bleeding, fix that. If the order becomes circulation, like we said, CAB, circulation, airway, breathing, it's because the bleeding control is the most critical. We got to fix that, okay? If cardiac arrest is then suspected, the order becomes CAB because chest compressions are essential also. We know that. Pediatric patients in shock often have increased respiratory, but do not demonstrate a fall in the blood pressure. There's a lot about kids. There's so much about kids, and it's like they asked me to teach you this a little bit, and you're like, I need like 2 weeks to teach this, so it's hard to teach you everything you need to know about that. I'm telling you, you need to read your chapter 2. Please read your chapter. Treatment. Basically, we're just gonna treat this. Treat my patient, not my monitor. If they need O2, give them O2. What is their skin color condition? I need to know their temperatures. If their temperature has changed, let's either warm them or cool them. That's very important. Changes in pulse rate. I need to know that because that's going to obviously indicate shock. If their blood pressure is going down, that means decompensated shock. You have to have ALS there because there's nothing you as a basic can do to fix it. I'm sorry, it's just not gonna happen. If somebody tells you at home that they started having, hey, what's their urine output? Well, it hasn't been a lot. And they're in a deep cry and they're not tearing. That's telling you dehydration. Sunken fontanel, which we know about that because I've already told you for dehydration. And then their conscious behavior. They're just like, they're just not acting right for a normal 6-year-old kid. Something's up. It gives you that idea of like, what's wrong with this baby? It's not right. Don't sit around. Let's don't waste time. Get them to the hospital where they can treat them a whole lot better than we can. If they're bleeding, you better be able to fix that in the field. You can at least slow it down. Again, y'all, supplemental oxygen is the best thing that you can do. Call for ALS fast because they can help with IV fluids, potential for airway replacement. We all have blankets on the ambulance. We should at least have sheets. And even if it's 90 degrees outside and that baby says, I'm cold, you better turn that dang heat on in the back of the truck. I don't care how hot you get. It's 15 minutes. You better make it work. Better make it happen because that keeping to the temperature of that baby is your job, your most important thing. Anaphylaxis. Whew. We know what that is. That is a allergic reaction that the entire body starts coming in. It's gonna have airway swelling, your dilation of the blood vessels. That's the reason why we need epi and epi as fast as we can get it. Um, Common causes we see insects, medication, food allergies. They ask now, you can't even, like, we have to know the allergies of every single patient out here because we can't bring certain medications out here or certain food because of allergies. Man, it's nuts. Everywhere you go, you got to be careful of that. And it's for good reasons. We don't need to cause harm to other people. Signs and symptoms: hyperperfusion, stridor or wheezing, increased work of breathing, an altered mental status, uh, restlessness, agitation, and hives. I'm not sure the impending doom. I don't know how to tell you. I mean, besides their attitude, I'm not real sure how to give you an explanation of that one, but that's what they say. So we'll let you know about that one too. How do you treat it? What are you going to do? Look, right here. Oxygen delivery. Maintain calm, man. Keep your composure. It's the best thing you can do. If you have the ability to do it and your protocols allow, give them an EpiPen. It's the best thing you can do. And rapidly go to the hospital where they're going to be treated with a lot more care than we can provide out in the field. So let them go out there. Get them rapidly. Rapid transport if you can't get an ALS provider there. All right, so hemophilia. I'm sure some of us has read about hemophilia and what some of the conditions are, but this is bleeding is gonna just happen automatically. There's nothing we can do to stop it. It's a dangerous drug. It's a dangerous situation. And if this is the case, do not delay transportation, but also don't apply a tourniquet for life-threatening hemorrhaging. Uh, that is one thing that you need to understand is it, it's a disorder, not an injury. Now, obviously, if they have an amputation, yes, please do. But if you notice you get there and you just can't stop the bleeding, and it's from bleeding on the top of their arm, don't apply a tourniquet to that because you're going to end up causing more damage and harm to them than you can imagine. Um, Here's some of your altered mental status. We use your AEIOU tips. That is another acronym. There's so many acronyms in EMS if y'all haven't noticed. Holy moly. There's a bunch. I don't expect you to remember them all. I don't use AEIOU tips. I've heard about it before, but I personally don't use it. A pediatric patient may not behaving in a developmentally appropriate manner could indicate an altered mental status, or it could have a developmental status. That's something that we have to think about too. The mnemonic AEIU tips does reflect major change in your altered mental status. So that's it's another acronym that helps you just remember things if you can. So check on 3411. That will help you write that down, study it, learn it, memorize it, burn it in your brain. Signs and symptoms will go very simple to the utmost coma. So we just got to treat what we see. Management focus on ABCs and transport. Right there, provide high flow O2 transport to the hospital. Just because we may not know, your service may not allow you to do a CBG out in the field. Pray to God that they do, because it's gotten to that point to where basics all over are starting to be able to do things in different levels of scope practices based on their state, which is amazing. So, and even some other countries outweigh us dramatically on what we can do, and some paramedics across the United States can do a lot of things. So, seizures, we know this is a disorder. It's electrical disorder of the brain. It is very scary if you've never seen one. If you've witnessed one and or unfortunately do have these, there's ways to, you don't know they're coming. There are medications that kind of help prevent them. Not gonna say it works every time. It could be from child abuse. Their electrolytes can be out of balance, can do that, which we all know high fever does it too. Hypoglycemia can cause that. Infections, ingestions, certain medications can cause this. Um, Poisonings, unfortunately, can be born with a seizure disorder. Uh, Recreational drug use for anybody. Obviously, head trauma, and it may manifest in very different ways. It just depends on the child, the age of the child. Seizures in infants can be very subtle. They can be small, or they can be just stared off in space. You have the abnormal glaze, that's like the 100-yard stare, or they're just their arms or legs are moving, kind of like they're, well, what's it say? Subtle in infants with abnormal gaze, sucking, and or bicycling motions. So yeah, I mean they can. There's you some very small signs right there. There's another table, 3412, common causes of seizure. I'll let that sit there for a second. All right, so once the seizure relaxes, this is called the postictal state. You need to know how long that they've seized, how often do they seize, if they've had multiple seizures, have they had one seizure. I need to know those things, because it's going to help me over time. The longer and more intense a seizure is, the longer it will take for the imbalance to correct itself. Remember, when they finally come out, they're going to be very droggy, very sleepy and disoriented, and they're going to have that overall confusion, and that's where they get real scared. Status epilepticus is a seizure. It's every few minutes, regaining consciousness in between. It's lasting longer than 30 minutes. If the patient does not regain consciousness or continues to seize, protect the patient from harming him or herself, and you must call for ALS, because now this person needs medications to stop it. These patients need advanced airway management. Sometimes, I will say sometimes, but they definitely need medications to stop that. Management. If we can get them to stop, once they've stopped, clear the mouth if you have to. You may have to suction. There may be a lot of spit. Clear that airway out. Put them in the position of comfort. Recovery position should be their left side. You want to provide 100% O2. And if you have to, you can bag them, but be cautious and be ready for a seizure potentially to start again. So have your guard on. Some caregivers will have given the children a rectal dose of diazepam, which is a seizure medication, prior to your arrival, but you need to know what that, like, you need to take that dose, like if it says 1 gram per kilogram or a max of, you need to take that with you. That's You need to know like what time it was given. Obviously, the route will be rectal. And your thing then would just be monitor that baby till you get to the proper, most appropriate facility, because there's nothing else we can do as a BLS truck unless that you say, hey, medication's on board, I need to call for ALS, and then that becomes their baby. Sorry, didn't skip fast enough. So meningitis, I don't know a whole much about meningitis, so I'm gonna just have to read the screens on this one because I'm not real sure. Um, it's inflammation of the tissue that covers the spinal cord in the brain. I do know it's caused by an infection, viruses, fungi, or parasites. If it's left untreated, it can be severe brain damage and death, or death. Being able to recognize that pediatric patient with meningitis is an important skill to have. These kids may have, the individuals at greater risk. Let's do this before we go over the symptoms. Majority of them will be males. There will be newborn infants. They do have a compromised immune system. They could be due to being born with AIDS or with cancer. A history of brain, spinal cord, or back surgery. Children who have head trauma. Children with shunts, pins, or other foreign bodies in their brain or spinal cord. And especially children with a VP shunt. Signs and symptoms, changes in the level of consciousness can range from a mild or severe headache to confusion, lethargia, and the ability to understand simple commands or interact appropriately. Uh, Children may also experience a seizure, which may be the first sign of meningitis. It says infants younger than 2 or 3 months can have apnea, cyanosis, fever, a distinct high-pitched cry, or hypothermia. Meningeal irrational is meningeal signs or terms used by doctors to describe pain. I know they do check for stiff necks. I'm not going to pronounce that. Y'all can read that. Is a bacterium that causes a rapid onset of meningitis, and it's going to often leads to shock and death because it's so fast. Children with that meningitis typically have a small pinpoint cherry red spots or a large purple/black rash on the body or face. Here's a picture of the legs. See how fast it comes on. That does not look like a small child. That looks like an older person. Just gonna say, I'm gonna let that be my point. But it says the figure on the slide shows in meningitis. Children with N meningitis typically have small pinpoint cherry red spots or larger purple-black rashes. I don't think that's a kid. We'll skip that one. All pediatric patients with suspected meningitis should be considered contagious. You need to use all general BSI. Follow standard precautions when dealing with these pediatric patients, and follow up to learn the patient's diagnosis. Treatment really is just provide high flow O2 and monitor that patient to the hospital. Monitor them until you get to the hospital. There's not a whole lot we can do besides treat them for the airway problems that they're suffering. So gastro emergencies and management. We talked about this the other day, so this should be pretty much here. We know if they get a GI issue or a problem, it is going to lead to dehydration because it can flow out of them very fast. So that may be part of the problem. You may have appendicitis, is very common in this. So that may be the reason why that they initially got you that you got the call for. They'll have rebound tenderness. If you suspect appendicitis, transport them fast to the hospital. Obtain a thorough history as much as you can. And it shows right there how many times they wet the diaper. The reason why we want to know that is so they're not dehydrated. We're not trying to play catch up from the get-go. We just need to know, are they dehydrated? How often have they gone, because that tells us their hydration rate. Are tears present? Do they cry? Do they have any problems when they cry? Is anything shown versus not shown? How many times has the child had diarrhea and for how long? How many days? Um, Poisoning that can be caused by any freaking thing in this world. A lot of it is alcohol, aspirin, acetaminophen, cosmetics, household cleaning products, and house plants. Um, some of the other ones are irons, prescription medicines that they find in the cabinet of the family. Some kids eat, they will eat or take illicit street drugs, and an overdose of vitamins just because they're cool. They taste good. I want more vitamins, and now they're over vitamin efficient. How about that one? Some substances can take just one pill because it all depends on the dosage that that pill has in it. Um, be alert for signs of abuse. This is a hard one. What substance is involved? What time did the incident occur? Any changes in behavior or level of consciousness? Any choking or coughing after this exposure? What is our treatment? Our treatment depends on what they ingested. Is there any decon that we need to do? How do we need to get rid of this? Do we need to, is this something that we can add water and get rid of it? Or is this something we have to brush off and that we have to remove with brushes versus we can wash it? ABCs are our most important thing because we need to make sure that that's secured, working. They do have functioning abilities of that. So that is a good part. ABCs are super important. Um, Activated charcoal. I would highly state reaching out to med control before you make that decision, before getting on a pediatrics patient, especially. A regular adult, no big deal. Fine, give them activated charcoal. That's cool. It says right there, activated charcoal is not recommended for those who have ingested any acids, alkalis, or petroleum products. Make sure you know what you're giving activated charcoal for, and not just because you're like, oh, it's a poisoning. Let's give them activated charcoal. It can cause much more damage because now you're trying to up the the ingestion or absorption, whatever you want to do it, and then it'll tear the airway. I mean, the respiratory tract up and all that. I mean, the esophagus. Sorry. Um, it is produced out there 1 gram per kilogram. Um, Pediatric doses are 12.5 to 25 grams. 25 grams is the entire bottle. They do come in different ways. Some of it is most of your departments and EMS, fire departments, and all that does carry the Actidose. That is the liquid. It's in a little white bottle. It's the way you kind of give it out that way. And they got to take the adults will take the whole bottle. Dehydration emergencies and management. So we all know about dehydration. We've all at least been there. We've seen people that way. It can be mild, moderate, or severe. Um, it is a life-threatening issue if a if a child's involved. You may have to take a kid to the hospital because they're dehydrated and they just can't get the water down. Maybe they were sick and they're flushing more water out, either vomit or through their bottoms, than they're actually keeping down. So that's an issue. Maybe they need to go to a medical facility so they can turn around and get some IV fluids. Cool. Okay, that's. I mean, I know it's scary, but we can do that. Here's some signs of moderate, mild, and severe. The mild is dry lips, gums, decreased saliva, and wet diapers. So your moderate signs is sunken eyes, sleepiness, irritability. Maybe I'm dehydrated. Loose skin, sunken fontanelles. Severe dehydration signs are molted, cool, clammy, dehydrated. I'm not sure what is delayed CRT. Maybe I'm just a little special. Oh, sorry, delayed capillary response time and then increased respiration. So here's a picture of some pretty severe dehydration for a child. That should never happen. Period. Period. That's it. I don't know what else you want to say. ALS is the only one that can provide more fluids because they have to start an IV on them. So, the faster you can get ALS there, the better off you are.
So fever management, anything higher than a 100.4, some places are changing that to where it may be like a 101 is a fever. Some causes of fever, infection, status epilepticus, cancer, drug ingestion, a lot of aspirin we'll call that. Um, Fever can cause arthritis. They can have systemic lupus, which means rashy across the nose. Higher environmental temperatures. Fever is the result of an internal body mechanism in which heat generation is increased and heat loss is decreased. So you got to think that's the body's way of trying to rid something. That heat kills viruses, so the body's trying to raise the temperature to where that virus is not comfortable no more. So that's why we get these viruses. You get these little 12-hour spurts of fever. Maybe there was a influx of a virus or an infection that you didn't know about until it may be a later cause that you know what it's from. It says right there, accurate temperatures are very important. Now understand, for a child, for a baby, it's got to be rectal temperatures. Your agency may not put that in your protocols. Um, if you can do under the armpit or under the tongue for older kids, that's fine. A lot of us have gone to these little temporal guns. I don't know how accurate they are. I mean, I think obviously right now everybody in the world believes they're the most accurate things with COVID going on, but I think there's a little bit of problem there because of you don't know the range that you're taking the temperature in, the surrounding temperatures are having issues. So that's just mine right off the top of my head, something to think about. Um, Depending on the source of an infection, the pediatric may present with signs of respiratory distress. You will potentially see the stiff neck from meningitis. The rash could be too. Hot skin, flushed cheeks, and in infants, bulging fontanelles. Well, that may increase. That may be because of the infection, if y'all can remember. You want to assess the patient for what's listed there: nausea, vomiting, diarrhea, decreased feedings, or headaches. Unfortunately, that is also the COVID route that they go to, too. Um, you don't want to just kind of chill around. You want to get these kids to a medical facility, seen, checked on, cared for. Cool. And whatever your policies, procedures are for communicable diseases, make sure you're on top of that. Febrile seizures. Most of the time, that only affects from 6 months to 6 years. They are fever dependent only. Most pediatric seizures are the result of fever alone, which they are called febriles. I have seen this in a younger than 6 months. It's characterized by general tonic-clonic seizure activity, which is very short-lived. The last fever is and it lasts. Sorry. So the febrile seizures last shorter than a 15-minute period, and there is no like confusion, no postictal, no like I don't know what's going on. But as the bottom bullet states, that is a sign of more serious problems. That is the body going, hey, hey. That's like your car giving you a warning light, and the warning light goes back off. Well, something's wrong, but it's trying to give you a sign as fast as it can. Something's up, okay, the light's off. Now it does it again, the light's off. So that is a need to get them checked out to a facility. It could be during the daytime, and the parents are very anti going by ambulance because of other infections. That's fine, but they need to seek their GP ASAP, like within 4 hours. That's very, very easy to get done. So that needs to be taken there. ABCs, the best thing you can do is when you treat them, try to cool them if possible. Uh, I know a lot of people are like, oh, just put alcohol around, cover them with alcohol. Man, be careful with these home remedies. Those are not FDA approved, so that can cause you some further issues. Oh, okay. Drowning emergencies and management. This is hard, y'all. Drowning is the second most common cause of unintentional death among children from the age of 1 to 4. Children often fall into swimming pools and lakes, but many drownings happen in bathtubs and even buckets, puddles or buckets of water, just because they don't know what to do. Older adolescent drownings when swimming or boating, alcohol is frequently is a factor. Even in a few minutes without oxygen affects the heart and lungs. This does cause life-threatening problems such as cardiac arrest, respiratory failure, and they can stay into a coma. Now, where it says hypothermia from submersion in water, I have read they've done studies and they've been able to recover somebody with no deficits for 3 hours. They were submitted into the cold water and they worked them until they were warm and dead, but they actually got a heartbeat back. They did have pneumonia, but this poor baby was uh, brought back. So it's longer than what we normally see. Um, Obviously, we know signs and symptoms if they've had like a water ingestion, uh, unresponsive, fast, slow, or no pulse, pale, cyanotic, abdomen distension means that their belly is full of water. Um, Number one should those 1 and 2 should be reversed. You need to contact ALS ASAP. Um, they need to be there because this person is going to ultimately need uh, an airway, and they're going to need ALS provider to be there. So if they're on the way and you've already contacted them, then you automatically go to ABC. Start there, give them something, oxygen, start clearing their airway, have suction ready, um, put them on high flow O2 if need be, if they're able to breathe on their own. If not, you're going to have to bag these individuals. Um, if it's from a diving accident and you suspect cervical injuries, okay, put a C collar on. That's what we're there for. That's what we want to check. And obviously the most important too. It's all of those are very important. I don't really know. I hate to say last important, but CPR, man, you got to get good, effective CPR. You can't just give CPR. It's got to be good and effective. Uh, we need to make sure that our CPR patterns are up to date, and we know we're not cheating them. How about that? Um, let's see. Unintentional injuries are the number one killer of children in the United States. Quality of care in the first few minutes after a child has been injured can have enormous impact on that child's chances for complete recovery. How you do what you do in the first few minutes is going to lay an outcome out for this entire time. The muscles and bones of children continue to grow well as adolescents, so you may or not going to affect that there. Coupled with the risk-taking approach to activities, adolescents are prone to fractures of the extremities. A fracture of the femur is rare in a pediatric patient, but when it does occur, it does mean massive blood loss. So think about that. Don't forget those. Let's say older children and adolescents are prone to long bone fractures, femur and humerus, because they tend to take more risks during physical activities. True, true, true. All right, so the physical differences between children and adults. Uh, they little, they smaller. And some children and adults have the same mental capacity because they just don't think. Injuries, forces of injuries do affect them, no. A child's head is obviously bigger than an adult, so more stress is on the neck. They will potentially land head first. So instead of when they slip, trip, and fall, and then the adult's going to catch themselves, so you're going to have wrist injuries versus head injuries because the poor little kid's head's going to fall first, besides instead of them trying to catch themselves with their wrist. Uh, I like the bottom one the best. I always assume the child has a serious injury to the head and neck until proven otherwise. It's always easiest to check that way. Be careful. Importance for EMT to understand physical and psychological characteristics of children. Children can dart out in front of traffic. We know that without looking. They will sustain high energy, head, spine, abdomen, pelvis, or legs. Children involved in these type of injuries, they will they'll go into shock a whole lot faster, because it's multi-system trauma at that point. So you got to make sure you try to take care of the best that you can. They just, again, they're not scared. So for them to not be scared of things, something has to give them the fear, and they're not taught fear. They have to learn fear. Some other injury patterns: sports, head and neck injuries occur at high-speed collisions and contact sports. Football, I'm not sure who all wrestles anymore or plays hockey, because we don't in the South. That's not a real sport. No, I'm just kidding. Soccer or lacrosse is not a real sport. That's too much running for some people. Be familiar with what your protocols state on removing helmets. That's very important. Is it just remove the face mask, or is it remove full helmet? You just need to know that so you can treat appropriate. Uh, Remember the head injuries? They got them big old heads, them poor babies. No, just but so they may end up having a brain injury because of the scalp, because of their head so big. So don't forget to treat that too. If you start to see nausea and vomiting, that is a very big sign of a head injury. You can mistake that and think that the abdominal cavity is affected, but look at their pupils. Their pupils will tell you telltale signs if they have any issues. Are they sluggish to light? Is one blown? Are they having trouble focusing on anything? Those are your tells. They tell you what's up. You should suspect a serious head injury in a child who is experiencing nausea and vomiting after a traumatic event. Let's say a good hit in the football field or a soccer, they catch a shoulder and start vomiting, automatically concussion. They need to go to a facility and be seen. Immobilize them, depending on their size, I would put them in a KED. If they're bigger than that, I would go ahead and put them on a backboard, treat them that way. But again, C-collar is important, so make sure you use the most appropriate size for C-collar first. The C-collar sizing is more important than anything else, also because if you don't have the right sizing, there's a lot of void space that now you have to accommodate for, and then you're playing catch up because you can potentially cause more damage to where it allows them to move a whole lot. If you bag them, sorry, if you board them, it says right there, children 8 to 10 or children no longer require padding of the torso can last. So if they're under that age and you start to see those voids, don't forget to place them with, like the padding on the backboard, head and shoulders and all that. So don't forget that, because you're going to cause more injuries, but the older they get, the less that they do require. So the padding can be taken out, and you can use the headboards or headbeds to secure the head once you get ready for transport. And hold on, you can use a headbed along with a C-collar to help you transport more secure. Chest injuries, we did go over that in one of the last chapters. I'm not going to talk about that. We went over abdominal injuries also. This one's kind of neat here too. So it talks about specifics, which one's going to develop shock more versus the other one because of the injury. Signs of shock in children, we see there, we just talked about those. It is the same thing in adults, but your cap refills very hard to judge the older they get. So you're not going to notice, cap refill changes there. The blood volume changes greater than 25 in children. You're going to have an increased risk of shock. In adults are 30 to 40 is going to notice a blood change. Go. Okay, burns. Let me look something on my screen. It doesn't talk about it here, and I don't know why my chart was not embedded into this, but you need to look up the rule of nons when we talk about burns. You need to learn that chart. I don't want you to just memorize it. I want you to learn it, because the rule of nines can help you out a lot. Children do not tolerate burns as well as adults. Really, I don't think none of us like to be burned, to be honest. But it's their body surface is a lot smaller than ours as adults, so they're going to compensate completely different. So now you've taken away their temperature regulating because of the burn. They're going to develop shock. And if there's an airway burn, you have to be very aggressive so their airway does not close up. Um, it says common ways that children are burned: exposure to hot substances, hot items on the stove, exposure to caustic substances. Older children are more likely to be burned by flames from a fire because they play. They play too much. That's what caused it. And I'm not trying to be ugly, but you got to treat that burn because those kids, no matter what, are going to compensate. You have to be ready for that. It has to be the compensation is going to be completely different than an adult. Uh, it says right there where it says, make sure you read that second one from it. Infection and common problem. Burned skin cannot resist infections as effectively. Sterile techniques should be used when handling. Make sure you always have clean gloves. Don't, if you can, clean the area off. Don't try to, when you cover it, don't cover it nasty and dirty. You need to clean it. Make sure you report any information about suspicious or appropriate authorities to the appropriate authorities if you suspect any foul play. Minor is a partial thickness burns, involves less than 10% of the body surface. Moderate is a partial thickness burns involving 10 to 20% of the body surface. And a full thickness burns are partial thickness burns involving more than 20% of the surface, or any burn involving the hands, feet, face, airway, or genitalia. Y'all got that? But look up the rule of nines. You need to learn the rule of nines. If the patient shows signs and symptoms of shock, prevent hypothermia by keeping him or her warm. You don't want you want to cover those injuries, those burns. Make sure you don't just lay a blanket over there because now it's going to get stuck. And then ALS needs to be there for show because that needs to have their attention. We talked about this about having green bones. The bones are not fully grown for children, so they have immature bones with active growth centers because we don't want their growth plates to get damaged. It says right there, growth plates are potentially weak spots, so they're subject to being broken. We talked about the green stick break in one of the other chapters. We talked about that. Pain management, there's really nothing we can do as a basic to provide them pain management besides ALS interventions. Besides just being sweet. I know some of y'all may not be able to do that, but I expect that out of all y'all is just to be sweet to these babies or to anybody. I know that we don't see them in their time of happiness, but bruh, they called you because they need something. So let's be nice for a little bit and take care of these babies, all right? All right, so we're going to use the Jumpstart triage. This is where it's going to go over here on how to do some disaster management, how to do triage in the field, quick triage. So the Jumpstart's intended for, what's that say? Patients younger than 8 years of age, weighing less than 100 pounds. So we're going to use 4 categories: green, yellow, red, and black. We should dive off. There we go. So the green means minor. It means they can, if you stand there and say, hey, if you can hear my voice, walk to me. Obviously, where it says infants, they're not going to be able to do that. They'll be able to follow simple commands. Yellow means it's spontaneous breathing. They do have a pulse, but they do respond to pain for a little different. So they're going to be a yellow, which means we can delay their treatment a little bit, just a little bit. All right, so when we go to red, means this is immediate transport. They must go right now. They're either their apnea, their posturing, they have respiratory failure,
breathing but without a pulse. They do have inappropriate painful responses. That is immediate transportation. So a black is the deceased or expected to die. They are apneic without a pulse or apneic and unresponsive to rescue breathing. So remember, if you start anything, you're stuck with them. It is very, very hard for somebody to do triage and not you don't want to come new into this field and do triage. I don't want to say it takes a twisted individual because that's not the case. You've got to understand more about life and how revolving, because EMS, like doing triage on a massive incident, it's going to mentally affect you. So you need to be prepared for that. It's scary. It's nerve wracking. I've done that multiple times. Unfortunately, in my career, I have tagged a couple black and had to walk off, and they do haunt you. That decision haunts you because you want to be able to provide the best care that you can for somebody instead of saying, nope, I got to move on. Because if you sit there and you try to do something to that patient, you can cause more to have harm and or die because of your decision to stick with that one. That's why you have to do it. So here's some jumps triage. If they're able to walk, it's a yellow. We put them green, automatic and secondary triage. If they're breathing, yes or no, they have their categories. You if it's a They say no, you position an upper airway, which means that you reposition them. If they are breathing, they go to immediate. If they go to apneic and they're not breathing with a palpable pulse, automatically deceased. If you give 5 rescue breaths and they do respond, they automatically go down into their immediate transportation. If you give the 5 rescue breaths and they do not respond whatsoever, automatically black tag them, they're deceased. And then it goes further down to where if you can answer all those questions on the left, you become a delayed, which means you'll be a delayed transport to the hospital. Again, these all take some training, some education, and some experience to get into that to do it. So that's why I say be prepared for that. Child abuse or neglect, man. This is where it gets serious here. Child abuse means that an improper or excessive actions that injuries. Hold on, let me start this one over. Child abuse means an improper or excessive action that injures or otherwise harms a child or infant. This includes physical abuse, sexual abuse, emotional or neglect. Over 500,000 children are victims of child abuse every year. If suspected child abuse is not reported, the abuse is likely to happen again, perhaps causing permanent injury or even death. And you must be aware of signs and symptoms of child abuse and neglect to report. You, as an EMT, are called to a home because of reported injury to a child. You need to automatically start documenting. You may be called to testify in abuse cases, so you need to be prepared for that. Make sure your reports are not POSs, that they pretty good and paint a good report of what happened. If it's very essential that you report all the findings and include any statements that were stated by anybody in there that were on scene. So document, document, document. Some things that you can see right there on the screen that says, ask yourself the following. Injury typical for this age. MOI reported consistent with an injury. A caregiver behaving inappropriately. Evidence of drinking or drug use at the scene. Delay in seeking care for the child. And good relationship between the child and the caregiver or parent. If that child is going up to them and they're holding them and the parents are consoling them, or you hear the parents over there going, shut up, you not hurt, don't act like that. What's that relationship built like? There's multiple different things that you need to ask to. Does this child have an unusual mark or bruising that may have been caused by burns, cigarettes, grids, or a branding? That's very serious. And does this child have several types of injuries? Bruising, burns, maybe you see some like stick marks on their legs. If they're just not a rambunctious kid, then that may be abuse. Um, it's something else. Is the child clean and appropriate weight for his age? Is it dirty? What's going on? What is the problem? What does the scene look like? It talks about is any rectal or vaginal bleeding. That may be signs of sexual assault. Is there an unexplained decreased level of consciousness for this child? There's a chart on 3416 that talks about a child abuse mnemonic. Imagine that. It's child abuse, basically broken out into a mnemonic that helps you remember. Y'all proud I haven't yawned in a hot minute, besides just right now. So we talk about bruises. What are the colors? So the color of bruises tells you the stages of bruising, our stages of the injury. Are there new bruises? Are they old bruises? Bruises to the back or to the butt where they've been beat? Are there any burns? And it says burns to the penis, testicles, vagina, or buttocks are usually inflicted by someone else. Oh God, I hope so. Burns that look like a glove or glues are usually inflicted by someone else. You suspect child abuse if the child has cigarette burns or a grid pattern. I hate talking about child abuse. I know it's very important, y'all, but I've worked many of these and they kind of get to me after a while. Are there fractures to the long bones of these kids that may have resulted in just hard, true abuse to where they weren't treated and they've had to heal back on their own? You should maintain some index of suspicion if an infant or young child sustains a femur fracture. That takes a lot of force, y'all. A lot of force. Talk about shaken baby syndrome. Infants may sustain life-threatening head trauma by shaken or struck in the head. This is a life-threatening condition called shaken baby, which we know the infant will be found unconscious, often without evidence of external trauma, and the infant may appear to be in cardiopulmonary arrest. Shaken baby syndrome, shaking shaking tears the blood vessels in the brain, resulting from bleeding around the brain. The pressure from the blood results in an increased cranial pressure, leading to a coma or death. If this is neglected, it is failure on the part of the caregiver to provide life necessities. Like examples are water, clothing, shelter, personal hygiene, medication, comfort, and personal care. Children who are neglected are often dirty, too thin, or appear developmentally delayed because of lack of stimulation. You may observe such children when you are making calls for unrelated problems. Abuse to children may appear withdrawn or fearful or hostile. They may not want the kids to answer any of the questions. Whomever called may be very defensive. Or if this particular person shows up, they try to be very hostile and get you out of the home. And the parent may say, oh well, they're accident prone, or they have a lot of history of accidents. Well, what kind? And the caregiver may be the abuser. So think about that too. That's the reason why sometimes it's better to separate them, but it depends on the age of the child that you have on what you are you going to get a full report or a half report. It is your job by law to report suspected child abuse. Supervisors are generally forbidden to interfere with reporting of suspected abuse. So if your supervisor says no, that's not what happened, you don't know, they can't prevent you from making a claim. It is law enforcement and child protection services will determine whether there is abuse or not. It's not our job to do that. We just report it what we think we see. Children of any age or either gender can be victims of sexual abuse. This type of abuse is often a result of long-standing abuse by relatives. An assessment you should be limited to determine the type of dressing and injuries require. Treat any bruises or fractures as well that you may find. Do not do the bottom one, because if you don't suspect any injury there, it's going to be very hard to document why you're assessing their genitalia of a young child, and that's not what you were called for. You can report it to the medical facility and let them handle that. Sexual abuse, be careful. Sure, the EMT or police officer that they're the same gender remains with the child. I've told y'all before, you definitely want to protect that child, shield them from people that may be in the area or room, or the back of the ambulance may not be tinted. Just be very, very cautious and open to seeing things that you have never planned on in your life in this field. Obtain as much information about the scene, the wellness, the overall care for these babies. Sexual assault on a minor is a crime, and don't be a dick and not want to work with law enforcement. It is your job to report this, and you should want to provide the best care for these children. So do what you can to do to be cooperative during this process. All right, so SIDS. The death of an infant or a young child is called sudden infant death syndrome, is SIDS. And that's when after a complete autopsy has to be done and it cannot be explained. It says right there 3,500 infants die annually of SIDS. I actually probably believe that's a little bit higher. The American Academy of Pediatrics recommends that the baby be placed on his or her back on a firm mattress in a crib that is free of bumpers, blankets, and toys so they can't suffocate. And the CDC recommends having the baby sleep in the same room but not in the same bed, chair, sofa as an adult. Some of your risk factors of SIDS. And the mother is younger than 21 years old. The mother smoked during pregnancy, and they are born a very low birth rate. This can happen any time of day. It's not just at nighttime. It can happen at any point, whenever. Uh, you will face you are faced with 3 tasks: assessment of the scene, assessment of and management of a patient, and communication and support of the family. It is a very sad ordeal. I don't know how else to explain that to y'all. It's very, very sad. Patient management. Victims of SIDS, they are pale, blue, not breathing, unresponsive. Other causes include overwhelming infection, child abuse, airway obstruction, meningitis. We'll talk about accidental or intentional poisonings, hypoglycemia, congenital metabolic defects. Start with your ABCs. You're going to work these babies unless you know that they're stiff. I don't know how else to tell you. Look for rigor mortis, dependent lividity, means blood pooling. That's obviously signs of death for those two. If any of those things are present, there's no. If you don't see any of rigor mortis or dependent lividity, you automatically start CPR. Just know that it's a touchy situation, y'all. The best solution may be to begin CPR and transport the child and family to the nearest ED. Deciding whether to start CPR on a child with rigor dependent can be very difficult. So you can't fix that. There's nothing that we can do that can fix rigor or lividity signs. So it's going to be hard for you, very, very hard. But imagine what these parents are fixing to go through. Assessing the patient, note any interventions that were performed prior to getting there. Did fire do anything? Did PD get there and try to do something? Well, what's going on? We need to know this because that needs to be documented in the report. Scene assessments. Check your scenes. What's going on? What did I see? Is there poor hygiene that's going on in here? What's the interaction of the family? Are they just not give two shits? Are they involved? They want to be very helpful. Excuse me. They want to be resources. They want to do. They want to be parts of things. Do note any report and behavior that is clearly not within the acceptable range as a physical or verbal abuse. The site where the infant was discovered. Note all items in the infant's crib or bed, including all pillows, stuffed animals, toys, or small objects. That's very important too during your report. Sudden death of an infant is devastating to the family. Y'all, I hope you realize that. You need to allow the family grief. That's normal. That is something to suspect. Anger, big part. Death of a child. Whew. In addition, any treatment the child may require, you must be prepared to offer the family a high level of empathy and understanding. Always introduce yourself to the child's parents or caregivers, and ask about the child's date of birth and medical history. This is very hard to do. So know when you do this, be prepared for this, that you're going to meet some resistance, some potential attitudes and remarks. It's not meant towards you. It's just a reaction. Don't speculate what the child's death could be. If the family will want to see the child and should be asked whether they want to hold the child and say goodbye. Um, the following interventions are helpful in caring for the family at this time. Learn to use the child's name rather than an impersonal your child. Speak to a family member at eye level and maintain good eye contact with them. Use the word dead or died when informing the family of the child's death. Emphasize such as passed away or gone or ineffective. Um, I would personally disagree with that. I think when it's dealing with a child, that the term death or dead is inappropriate. I think it should be, past or they're gone. That is personal. That's something that I've delivered death notices before, and it's a personal level that you take when you know names and you don't have to look at notes and stuff like that. So I don't know how else to teach you guys about that, but it's a personal level that you have to get to. You need to get down to this person. Be prepared to stay with them for a hot minute. Here it talks about ask this person, do you want to get in contact with a clergy, a family member, a pastor? Um, just hmm. So keep your instructions short because you have to remember this person is not in the most thought process right now. Um, if it's a child, do not remove any equipment that was used to attempt resuscitation. Like, do not remove a tube if it's stuck down there. Don't remove pads. You can remove the leads and the cords, but you just need to leave like the NPA or OPA. Those have to stay in place. Wrap the child in a blanket and stay with the family while they hold the child. Law enforcement in the corner should be there to take care of some other things like that. Um, Unfortunately, I say that it is easier to try to remove the child from the home and do those ALS procedures, CPR on the way to the hospital or things like that. It's a lot easier than trying to do it inside of the home because that's the last place that those family members remember that baby being. Everyone expresses grief in their own ways. It's the 5 stages of death that you have to go through. and that you may see those. You may not be around to see those. I relate the 5 stages of death also to the 5 stages of divorce. Some EMS systems arrange for home visits after the children's death for closure of the EMS team. Some family members may try to come visit and say thank you. I highly recommend that you, even for your first one, no matter what age that they are, that you reach out to somebody and talk about it. Let them know it's okay to grieve. It's okay to have questions, but I highly recommend that you speak to someone about that, and that you treat yourself for personal care. You're not just expected to deal with this and move on. It's okay to need assistance. It's going to be very, 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 very stressful. You need to be alert for signs of post-traumatic stress in yourself, nightmares, restlessness, difficulty sleeping, lack of appetite. It's okay to ask for help. If those signs occur, reach out to somebody that you trust, and it's not going to try to blow you off about them. There are some of those folks in the field that like suck it up, Buttercup. It's not always that hard. I've been affected my own way. Um, I have many unfortunate war stories that I could pass, but that's not my job, is to war story you to death. But guys, I do push mental health upon the provider themselves. Not only do things for you, make time for yourself, make time for you to treat you. If not, you will burn out super, super fast. Um, Apparent life-threatening events. Infants who are not breathing, cyanotic, and unresponsive sometimes resume breathing and color with stimulation. Apparent life, it's ALTE. Never heard that one. Sometimes they choke or gag. They just need some little basic render of care, and they'll change pretty quickly. After a life-threatening event, they may appear healthy with no signs of illness or distress, and they must complete an assessment and provide rapid transport to the ED, because remember, they going to change. Remember that. They will, and the physicians, ED, MDs, that's what they get paid for, to check all that crap out, not us. Depending upon your service, they may only allow caregivers to ride in the back of the ambulance, but at the same time, it's your ultimate decision on who rides or who doesn't go, no matter what your policy state. Okay, if you're not comfortable with that, then you don't let them ride with you. It depends on, if they're not calm, then they don't ride with you. Unfortunately, this is the end of this chapter. It has been a very hard, difficult, long one to go over. I know that I probably have lost some of you folks through this process. Some of y'all are like, what the hell is he talking about? I get it. I understand. I know. I've been there myself. I highly suggest that you guys read your book, listen to my boring lecture as a reminder, as a refresher. But here's your code for the class test. It is money sign 83 question mark exclamation mark. Money sign 83 question mark exclamation mark. Please let me know by email if any of y'all have any questions. Like I told y'all before, I will be busy. I will be not able to answer my phone or text messages or Facebook messages that any of y'all send for the next week. I will be out of service, taking some mental time and family time. I wish y'all the best of luck on this test. Please let me know if y'all need anything, and I will talk to y'all at a later time.